Can co-host me now? Co-host me now? Dr. Ness, we're ready to go.
Okay, good morning, everyone. Yeah, members of the Health Education and Human Services Committee, staff, our attorney, it's very nice to be here. I go here this morning. My name is Andy Ned. I am the current city delegate in the 25th Navajo Nation Council. And I come from a community about 15 miles north of the nation's capital, a community just north of Oakland called Radicka. So I work with our communities of Fort Defiance, Alamo, Crystal, and Red Lake, and proudly serve here on the 25th Navajo Nation. At this time, I will call this meeting to order at 10:11 a.m. And Chair James is back in Winter Rock, but his finance committee has a convening today, and we did pass the Department of Health's budget last week. And so he sit in on behalf of our HES committee to ensure that there are no additional questions, and everything is provided there for the budget and finance committee. So I've been asked to assume the presiding chair pro tem today, and I'm happy to do so as well. So this meeting was called to order, and again, as a friendly reminder, please mute your phones and any inside conversation out of respect to our presenters as well as staff. Those of us joining online, you may take that outside. So I'm going to do a roll call. Phenomenal, and you assist us with roll call, please.
Yes, Mr. Chair, members of the Health Education and Human Services Committee, you have your roll call for the regular meeting for August 21st, 2023 at the Tuba City Regional Health Care Center conference room. Delegate Helena Begay. I'm present. Thank you. Delegate Vince James. Delegate Dr. Andy Nez.
Present.
Thank you. Delegate Vice Chair Jermaine Simonson.
I'm present.
Thank you. Delegate George Toad.
I'm here.
Thank you. Delegate Curtis Unito.
Here.
Thank you. Mr. Chair, you have 5 members present. That constitutes a quorum.
Thank you, Ms. Benali. And for the record, Honorable Chair James is excused for today's issue. To do that, I will move on to invocation. From the city regional staff, if somebody can assist us with opening prayer.
Honorable Clinton Senior will do the opportunity invocation, sir.
Hello. I am one of the 4 members. I represent Coal Mine County. There's 10 of us. 4 members. 8 top players and 1 copy of Around there, we've got shared area. We're operating at 600 area. Without a. Advantage of the laws that the government has. But a can. Not. We've got representatives from non-profit. I would. And most of the western area. They. There's. They should be there at the line. They told me. To the city. Yeah, fun. So it's a place you can have. Council come here and see us. See how we're going with the. 2002. So question. Operating.
Yes.
Picture. There's a list of connections. The rest is for a new. Now, come. That was when we found for 4 years. Now, they were for the main problem. Of the problem, but yeah, they really found, pretty sure they took on the township. When we came on, shoot out everything as well. We will cut on the. There's something only to keep up. You can fight stuff. 10 years trading from the floor. We have to do. Remember at the floor. Maybe they can institution set up. Not faithfully.
Mystery and they fight this over conveyed on battle action after the destiny tackle. But that the the benefit, I can't. Moving on, colleagues to announcements, any announcements? Going twice. Going 3 times, no announcements. Went on to item number 2, recognize guests and visiting officials. We'll all introduce ourselves. We'll go start here with our colleagues to staff. Then we'll go around the room. If you can do a very brief introduction, your name, your title, your plans if you'd like, and we'll move on to the next individual. So just a moment to briefly introduce yourself to our team here, and then we'll introduce ourselves. So again, I did mention for anyone who walked in afterwards, my name is Andy Nez. I come from a community about 50 miles north of the nation's capital, north of Port Defiance, states at the the top man significa che non ci sono alzare sotto un difficile non è se lo per ci la dei parti non ci sono in such closure and storage and network. Currently presiding over today's meeting, and I work with our communities at Port Defiance, Sawmill, Crystal, and Red Lake. With that, I'll move it on to my colleague here, she Honorable.
Yep, been George Toll from Eastern Agency. I work with Pay Chapter, Rock, all the way up to Torreon, Counselor, Overseas. I mean, sure, I'll give us a student from the army that's young. I don't know, I think that's chill. I do people, where this one's not a non-strength. Yeah, but I think. Yeah, they've been say, courtesy of insurance, yeah. Northern Agency, they go, say, last year, for the chief was just team, kind of 76, or bonus, auto, but one not semi big or sunset, and we are mixing water, red visa, in for the condo, he must get.
Vice Chair.
Yeah, tape Bennett, Shay Yaz, your name is Langenson, Ado, Shishin and she dog for the kind of like she said that she that not dogs, yeah, on you that she Ado, they, the Eugene, but caught belly, fish, but that's the unintentional, but not shot on the Black Mesa, Forest Lake, Whippoorwill, Pinion, Hard Rock. Hotel a Shannon Shishkan. Ado, but a hundred invitation nale, de coffee, Chanel Ramford or in Ram and Betty Herder. Is she like that? Case I don't rent what they paid out of me. Although, yeah, I think that you can go to.
I can't, Vice Chair.
Oh, yeah, it's actually able to be that good morning, all the things that I'm creative. She, delegate Helena, yes, the very entire. It's really good. But the chief, we go, it's a fun about the team and I pay that, as you don't need to help on what that's doing. I don't on that. So now, boss, how to see go, they shot, they shot here, I don't that team, they're like taking for. It put out a but they spot, so I mean, for income, for the AICA. The country can't need to share. I would see for the home, this is the old hospital that I was born in. I always say that you go back and roll around for you and reporting that. But I didn't want to do that. One day I came in, there was a bunch of offices in here, and I'm like, well, I want to roll around in here. So this is where, my late mom gave birth to me, and I acknowledge my board members. She's there. I learned from Heidi for those 3 yards. I know for the chief. I don't know. So, by the way, yeah. Those 2 yards. That's good from different support me that from my delegate regions. But she so I think support staff and anything. Put all the who's their information with one another and she not put you in the support that And then my. The person that I really good contact with is her. We always send emails to each other. For share and to be in the
Kihashima, Arapadon, Alapas, Ms. Kristen Flo.
My name is Kristen Lowell and I work at the Office of Legislative Council. So I'm the attorney advisor for the Health Education Committee.
Akashi, we do have two staff. Thank you for always being here and prompt with us. So we'll start with Mr. Nali Shaman,
Okay, thank you. Good morning, everyone. My name is Angelina Benally. I'm the legislative advisor for the Health Education Committee. I work with the Office of Legislative Services and that is I don't send out with you, but it's great meeting that you know other co-find when I'm reaching from Karen Canyon, when you take it to audit committee and it's kind of like east of Tallahassee for those of you in small community, but you know we're there and I thank you for your invitation. You know, it's very nice of you to invite us to your facility, and it's much appreciated. Thank you, Steph.
Good morning, everyone. Yeah, Karen Thompson, legislative assistance. Yeah, that's how I work with the committee. Look at you said the shadow 20 the other can't any slow the bettersion of a chain to buy the chain of touching additional. Yeah.
Good morning. I'm Melissa Goad. I am the CFO for Tuba City Regional Healthcare Corporation. I'm celebrating my third month anniversary today with you guys.
Morning, y'all. I've been in Albina to be Patterson. I'm the chief compliance officer for the organization and good morning, welcome.
Good morning, I'm HR Yadi Mushia, that was at the team. Look at the name of I am the chief human resources officer. Welcome.
Good morning, my name is Sean Davis. I am the Chief Information Officer. 200 Michelin, Syndicate Membership Team, Tiani,
Yeah, and shit, Natalia Coffee and shit could excuse me, Michelin, but then he was just Jean, Tiani, that should say, a senior vegetarian, and the chief anxiety officer. Good morning, I'm from shade on small.
Morning, everyone. My name is Kyle Black. I'm the Chief Sports Service Officer. Also in the national it's not a
Good morning, welcome everybody. I'm Dr. Yadav Bhaktim. I'm the Chief Medical Officer.
Good morning, I'm Chris Burnside and I'm originally from Concord, New Mexico, Dodger County, our delegate from the eastern side of the reservation. So it's good to be here. I'll be a public information officer about that, so I can take it on. If there's.
Yeah, good. Thomas McCain, yeah. The Senate Commission, though, the chief, I represent the Cameron chapter on the Tuba City Regional Board of Directors. And I've been doing it for the last 5 years. And welcome.
Okay, Chancellor Nez, you check the outline you're speaking.
Este. Franklin Fowler, quiero capitole national. Senator Ray, that we have been. I don't know that, so. Cool. Okay, that one, final client. Yeah, that's gonna be. Sometime on the cup, I make it. So we got some excellent staff. Usually get that report, not all. It was a cheap name, state or I said, it's up on, that's the same. Yeah, on it, that's state or that's the like. I don't care, I'm on time.
Yeah, okay, my name is Howard Brown. I'm one of the attorneys for Tuba City Regional Healthcare Corporation. Good morning, it's a pleasure to be here.
Good job.
Yes, yes.
Morning, my name is Ron Huntington, with the tribe represent village of Norfolk down here from Sunline. Welcome. You guys have been Shay, Lionel Sodium Shed, deep money in the show, comes on the sheet. Just a shade of I think the sheet know. I'm a board member, I represent the community machine. Welcome, honorable council delegates. Welcome, good morning, Shimon. Council delegate, Lingham Gate. Good to see you outside the chapter meetings. Good to see you. Good to see you. Thank you.
Good morning, my name is Leila Sidney McCain. I represent the Copper Mine chapter on the board. And Kansas County is not being the county, but she go, yeah, money. But she too much in Thank you.
Good morning, my name is Carly Silva. I represent the Chicago.
Out there, Brandon,
Good morning.
colleagues. Quindi dedicare questi studi, poi c'è da succedere per varie vicine. Fare board members, welcome.
Yeah, it's Ed Benning, share justice spirit and share though. Not creating the emissions to make the budget though. Yeah, I need to share the budget, the door after go for you to the Machado, the age and the budget appreciation to have.
Morning, guys. Shay, Joette Walters, your chair. Oh, sorry, I'm going to see you first. Sorry. I'm CEO of the organization. I'm Joette Walters. We're going to Green Mountains at the Bandit Nasha. I started working here years ago as an RN. My plans are much fun with Anavani, that's a steam, that's a train on it.
My name is Rebecca Springer and I'm the chief nursing officer here at Concord. Good morning, everyone. My name is Lisa Butler. Let's started as you say, and we said it's good to raise my father, so I've been on with it. I'm a senior executive assistant to our CEO and our COO, and our board of directors.
Good morning. My name is Julius Young II. I'm the chief operating officer. I don't know but I need to chair. I'm originally from Pianta, but I've been here for Tuba for 10 years. Thank you. Yeah, staff. Christopher Pearl agency, board president. It's not she won't take. Yeah, it's been fun.
Yeah, also with us, is the Honorable Shinola. Okay, so we're just gonna introduction. Short and brief and.
Well, no, I'm not home. I'm home. I literally,
First time.
yeah. Good morning, with all, Health and Service Committee, Vice Chair, committee members, colleagues, staff, legislative branch. I don't know, I did, Healthcare Corporation Board and staff, so, good morning, they are solving Michigan. Now, Kaibuna, which you know, Nancy up look at me, that's a shame, those things that I would also it was a story that stand there, I don't get it from Phoenix, army men and hot rod cars, you see. One story, and they're so they're so country. So maybe yes, and I'm with United Ocean, hey, I don't know much, United Ocean, sweet go, I didn't. I didn't. Yeah, I don't really appreciate you guys coming out today and this morning I was at I serve on Resource and Development Committee, Project Western Agency, Ben, so I was over there this morning. And spend myself in there and come over here and have oversight of the Western raising community. Yeah, thank you.
Otto, is there anyone online who wishes to introduce himself? Going once.
Good morning, Chair, committee members. This is Michelle
Going
Moore,
twice.
legislative analyst.
Do we have anyone from the Office of President and Vice President?
No.
Okay, hearing none, we'll proceed. We still use virtual to allow participants to listen in on our meetings. However, for us as delegates, we have to be here in person. So just wanted to highlight that area.
Mr. Chair.
Moving on to review and adopt the agenda. Staff, can you assist us there? First reading.
Yes, Mr. Chair, members of the Health, Education and Human Services Committee. You have your proposed agenda for the Health, Education and Human Services Committee, 25th Amalgamation Council, regular meeting, August 21st, 2023 at 10 a.m. Presiding the Honorable Pro Tem and Dr. Andy Ned, and also the Honorable Jermaine Simonson as Vice Chair. Place at the Tuba City Regional Healthcare Center Conference Room via telecommunication in Tuba City, Navajo Nation, Arizona. One, call meeting to order, roll call, invitation, announcements. Two, recognize the guests and visiting officials. Three, review and adopt the agenda. Four, review and adopt the journals. None. 5, receiving reports. A is a report update from the Tuba City Regional Healthcare Center. The topic is to present the annual report of the Tuba City Regional Healthcare Center Corporation. Presenters are the Tuba City Regional Healthcare Center, Tuba City, Navajo Nation, Arizona. It includes Sacred Peaks Health Center and the Cheat Health Facility. You have your TCRHCC Senior Leadership Council, which is the administration. You have Joette Walters, Chief Executive Officer, Julius Young II, Chief Operating Officer. Julia Billy, Chief Quality Officer, Melissa Gold, Chief Financial Officer, Dr. Del Karam, the Chief Medical Officer. Rebecca Springer, Chief Nursing Officer, Shar Yazi, Chief Human Resource Officer, Natalia Hatapi, Chief Ancillary Officer, Sean Davis, Chief Information Officer, Dolly Small Canyon, Chief Community Health Service Officer, Kyle Black, Chief Supporting Service Officer, And Dr. Thomas Gohider, Chief of Staff, and Dr. Elizabeth Lally, Chief Internal Medicine. You have your TCRC, HCC Board of Directors, Christopher Curley, President, Franklin Fowler, Vice President, Justin Beard, Secretary Treasurer, Dolly Lane, Member, Timster Nez Senior, Member, Thomas McCabe, Member, Leila McCabe, Member, Lionel So, Member, Carmelita Homer, Member, Ronald Hamyatewa, Member. And also you have, in addition to the staff of CCR, to the staff of TCRHCC, Mr. Howard Brown, attorney. 6 old business, none, new business, none. 8 closing meeting announcements and adjournment. Mr. Chair Pro Tem.
Thank you, Ms. Finale. I get a motion. Motion by Honorable Nancy Gay, seconded by Vice Chair Simon Mason. Colleagues, do you have any additions or changes, modifications for the proposed agenda? Honorable.
Thank you, Chair, members of task committee. Last 2 weeks ago or a week ago, we asked for plan operation. The health, all the plan operation that deals with this department. That was requested by our legislative advisor. And my understanding was never provided. So, Chair, I'd like to ask about those. You need a copy of it. You have your house, housing plan operation, also the board plan operation bylaws, whatever the policy you have. This is the public information. I would like to ask the administration to provide that for us so we can look at it. And we'd like to have that copy, Chair.
Okay, Honorable Toll. Ms. Finale, do you have an update on that? Were you able to retrieve any information?
No, Mr. Chair Pro Tem and members of the Health Education Human Services Committee and Delegate Toth. No, I didn't receive any beforehand. However, we did receive a packet. I don't know if it's included in here, but perhaps the Tuba City Regional Healthcare Center staff could retrieve the policies for the Health Education Human Services Committee, which Delegate Toth had mentioned, the plan of operation, the personnel policies, housing policies, and the board bylaws. Thank you.
Thank you, Shannon. Ms. Finale. You've heard it here on record. Ms. Butler, do you have a response? That's how you raise your hand.
Okay, I'm sorry, I just wanted to, I sent the email with the link and it has all the documents that were requested. So it's in the link that was sent in the email. That was sent last week to me.
Okay, colleagues, I prefer links. We get so many papers, it's and ridiculous. For me, as one delegate, but colleagues, did you guys need a copy of it or will a link suffice? How many pages do you consider?
Okay, so these are all it's in the link. You know, the articles of incorporation.
My question is, how many pages with all the documents?
You can buy it with that.
Okay.
It's probably-
Okay, we'll rely on the link, colleagues, but like a lot of paper.
Mr. Chair, I could go,
Ms. Thompson?
Mr. Chair, I can go ahead and provide Mr. Toth with the copies once we get back to the office.
Actually,
That would be okay.
when we get back to the office. It's on your, there's a link for you. But a copy, Ms. Thompson, without doing, we'll get back.
Get the information for this party.
All right. Okay, well, roll on the link. Thank you, Ms. Butler. The only question I have is, I know that there are some individuals who introduce themselves that are not listed on our proposed agenda. And so typically what will happen is when you hear a presentation, only those who are listed will be able to speak on the subject matter. So I don't know, CEO, if there's anybody who is not on here, such as your attorney who's not listed on here, would be able to be added so that way we can approve the agenda with their names on there.
Yes, I would like to have them. I would there's any questions and, that can be recognized.
Okay.
And, also recognizes Alvin Tooney Patterson, our Chief Compliance Officer.
Okay, with that, we did have a motion in a second. Colleagues, I'm going to a roll call vote. Honorable Harmony Nice-Begay.
I agree.
Honorable Vince James is excused. Honorable Vice Chair Janine Simonson. Honorable George Stone. Honorable Curtis Stevens. Okay, with that, colleagues, we have 4 in favor, 1 excused, Chair Pro Tem not voting. So with that, we go on to the next item. 4, review and adopt the journals. There are none. Moving on to 5, receiving report update by to the City Regional Healthcare Center. So I'll give you just a brief moment to come up to the table here. To our presenters here, we do have standing room procedures. So the expectation is that we will have 20 minutes to give your report. I know it's quite lengthy, but at the end of our 20 minutes, if there are consensus to offer you more minutes, such as 10 minutes is what we typically provide. But we'll go ahead and lead that route. Following that, we will entertain questions for our audience as well as our presenters. I will go to our S committee members for questions. Following that, I will give you an opportunity to be recognized to respond to those. After you are done responding, CEO just give me the indication that you're done responding. We'll do any follow-ups or any additional questions. Also with this proceeding, I will honor both those comments or questions as well, should you have any. As a member of the 25th Navajo Nation Council, we are serving on behalf of all of our Navajo relatives across and the Navajo Nation. So, thank you, and I think the question is out of the table sheet. If there's more questions or the consensus issue on 10 minutes for non. So with that, we've done introduction, so we'll give you the 20 minutes here. I'll kind of give you like a 5-minute warning, and then we'll come back. See you. The floor is yours.
Because let me just open up real quick again. Thank you so much. So, thank you both staff as well. On behalf of the board of directors here, this is about cadence, and I know even then, by each and then I know as about cadence, we do have veterans on serving on the board as well, that recognized. Mr. Van Soul is also United States Marine. Mr. Thomas McCabe, U.S. Army. I served on the United States Police. It's all about cadence and so chapters though. We're working with the Hopi Nation, like Ron and Nicola. So I'm certified on this moment. We're very unique here to the city, representing 3 tribes. We can I think so. Let's say they're all people, maybe people they have been a lot of questions. But then power and Davis, Secretary Treasurer, Mr. Beard of the makeup the executive committee and board. So I don't want to recognize Darwin Names, the senior member of our board, 11 years. That's the Honorable Kenneth Singh, the former council delegate, and the fire police officer. Board members are really well.
Yes, and thank you for this opportunity to present to you today. We've been looking forward to this discussion, and so I have several of my senior leaders here. With the 20-minute time frame, we'll kind of run through this report. Many of you got the binded report. This is a complete report with all the attachments that were sent by the link. I'm just going to run through these, and then as my senior leaders, when they have questions,
address any of the questions you might have. But there's quite a bit to discuss or to at least share with the community this morning. So I have to move straight into our report and talk about in 2002, we became a 638 facility. So last year we celebrated our 20-year as a 638. And since then, we've been able to, I believe, do a lot for the community, addressing and working with the community, collaborating with them, with our board members, and making healthcare better for this service unit. As you know, our service unit extends north, starting out all the way from the T, all the way into a clinic way out in Flagstaff. So this is the main campus. We are a 73-bed hospital, inpatient hospital unit, with outpatient services, primary care, in the 3-story building outside. And then in 2019, we started oncology, which is unique to any of the Indian healthcare services, tribal health organizations in the lower 48 states. And so as such, we have, and then with COVID, things really got disrupted. And so now we're starting to see our patient volumes come back up to pre-COVID levels. And so we have a few slides in here about patient volumes. I have a number of slides here on our COVID response that when I go through our questions, we can address those. But I'd like to go over this capital priorities. I don't have my number 11 on in your book. And just kind of highlight a few things here as we go into the PowerPoint slide with Mr. Young as he talks about them. So we received at about 120 to 24 million in COVID stimulus monies from various agencies, and that really helped in a number of capital projects of improvement in the work areas for safety. And really helping in this COVID response. And so we're going to highlight some of the projects and some of those things we did in that response. A number of slides here presented by many of our chief medical, nursing, ancillary support services. One of our biggest challenges in need is recruitment and retaining staff, but even greater to that is housing. And so we're working on trying to address the housing issues here for our staff. And that has really challenged our ability to recruit and even retain folks for lack of housing. Mr. Young will go also into a little bit of the malformation analysis that we're working on along with collaborating on these projects. Finding land and beginning the design and construction on a lot of these projects that we're looking forward to doing in our priorities and our initiatives. Also with that, we look forward to the building of our Broadway Gap Health Center. That again is IHS funded, and we're working with IHS as we are just wrapping up the design and heading into the construction phase. We've done a number of campus renovations, and I'm not going to steal Lisa's thunder. He'll go through some of those things, including not listed here is recently the domestic violence shelter, which we are working with our nation. Social Services Department. On to the next page, we have our public health response. We've been doing a number of things in community health services. We also have mobile vans that go out into the community. Our chief community health service officer, Ms. Small Canyon. She has a mobile health program that we send medical mobile and dental units out into the outlining facilities to the various chapters and bringing healthcare out to our communities is the objective of that. We also have cultural language programs, and there's some slides in here to describe that program and what we're doing to support our patients with Navajo interpreters, support our staff with education for Navajo language and teaching our staff. And then training also our staff to become interpreters themselves. We've done a number of initiatives around education and mentorship. I am a product as well as the chief operating officer here, and you'll heard Mr. Kyle Black introduce himself as a mentee. We also have Ms. Atagli, several of us here who were part of the prior CEO's executive mentoring program. And with the board as a vision for the 638 hospital when it first was incepted was to really build and grow our own with that concept. So some of us have moved through that process of training and education and mentoring to the roles that we are in. And as I had mentioned, I am a product of that.
We also have a number of IT initiatives, as you're well aware, and probably with the COVID became more adept at using technology, and we're forced to do that to have virtual meetings, but also in the hospital realm. You know, there's a lot of initiatives and moving to electronic health records, and we did so in 2017 with the purchase of a commercial product, Allscripts, which is now called Altera. I know IHS is looking forward to adopting something of that sort, although they haven't moved in that direction. But all of our medical records and documentation is now on computers, so we rely heavily on computers and technology. Also, a lot of our equipment also is integrated together with the EHR, so that has become a big initiative over the past several years and ongoing in using technology. We also use technology for reports, and some of the reports you're going to see today in this and with all the links are electronic reports produced from our data, from the data that we are now collecting and able to do. Also forgot to mention at the beginning, as a healthcare organization, we also are accredited by the Joint Commission. And so this year, and the Joint Commission, they provide unannounced surveys. So we have a survey window every 3 years, Joint Commission comes to our facility. It's unannounced. And so they came in March, they did our hospital. And we've been now since approved or accredited by the Joint Commission for our hospital program. We've also been approved for our outpatient clinics, the patient-centered medical home accreditations, as well as our durable medical equipment, our home programs is also accredited, and also our lab. We have accreditation for every 2 years. We also receive accreditations and verifications of certification for our level 3 trauma. So we are the only level 3 trauma in this area that I'm aware of, like among IHS. I believe we're the only level 3. And so that again is another evidence of our standards, meeting best practice for trauma patients that we receive in our community. Also in this report, I listed on page 16, all the other accreditations and certifications that we are we voluntarily work towards and getting those accreditations, and there's some problems with that. The government teams that have made those accreditation certifications possible. So those things, there are a lot of surveys, a lot of audits, and various things that our senior leaders do to ensure that we maintain our accreditations. Moving on to page 17, I'm sorry, page 18, but page 20 kind of highlight a few of our stats. And this is an example of how we're using data and looking at our numbers, our volumes, and even making evaluating decisions. Page 20 shows inpatients. Since the COVID, our inpatient or hospitalization admissions have really have kind of just gone down. But that's national. That's you don't see a lot of people being admitted as much as they used to. We're seeing more of the volumes on that outpatient. And so, as you can see, the blue line, the dark blue line, are our year to date, our 2023 inpatient discharges. So you can see that it's not as big as it was back in 2021 or 2022. So that's just what we're seeing now with a lot of our acute patients. When they do come, a lot of them are a lot sicker and more acutely ill. Some of those services we don't have here, such as cardiology and gastroenterology. And for lack of those services, we have to still send those patients out, generally, usually out to Flagstaff or out and beyond to Phoenix. Page 21 talks a little bit about our ER visits. ER visits are continuing to increase. We see a lot of our volumes in the ER. The gray line shows that it's starting to climb up. It's been following recent trends, it's been following the trends from the prior year. But we anticipate as we head into the flu, as we head into the fall season with flu, and then we still get we're still hearing COVID out in the outpatient clinics. We're still seeing people having those symptoms. So those ER visits continue to go up. And then page 22 is our outpatient visits here. We see the volume really starting to go up closer and beyond to those similar to pre-COVID level. So that's just a picture of our patient volumes and what we're seeing for the last, this year and the past 2. 23 shows patient volumes even before COVID, when we first became the 638 in 2002. And then 2019, that was right before the pandemic. And then, of course, now you have the data for these past years. So numbers are starting to come up, although we see on the inpatient side, they're not as huge as they used to be. Before I turn the time over to Julius, really quickly, I want to talk a little bit about CMS. One of the things we've done with CMS, Centers for Medicare and Medicaid, our oncology program, we started in 2019. One of the things about our oncology program is the specialty meds are very expensive. Pharmacological treatments and therapies are very expensive. I'm not sure how familiar you are with how billing and healthcare reimbursement is, but for tribal healthcare, IHS CMS gives us a flat rate. $620 is their flat rate for outpatient visits, and oncology falls in that. So since before we built this program here, we've been talking to CMS and getting their attention to one, IHS doesn't have IHS only covers primary care. So they are that flat rate that's they propose and always supported. It doesn't really work for specialty services. And so we've been working with CMS, and this year, just recently in early part of August, they posted a proposed rule to allow specialty medication a carve out from the AIR or the OMB flat rate to allow medications to be reimbursed, specialty medication to be reimbursed, I'm sorry. It's open for comment. It's a proposed rule at this time. We're working on our comments and we'll be seeking support as we work with CMS towards getting that accomplished. And hopefully we can get better reimbursements for specialty. It wouldn't just be for us. It'd be for all the other IHS, other tribal entities that would like to pursue specialty type services. So with that, I'm going to turn the time over to Julius.
Thank you, Joyce. I'm going to quickly go into the project in terms of it. As you noted, as the duet noted, basically the funding that we received for the COVID in terms of it, we're able to take advantage of that and turn a lot of our patient rooms, even exam rooms, into negative pressure rooms. And we did this at Sacred Peaks Healthcare. We were able to do that. And so most of you that you see in Flagstaff, we have that facility there. And then basically the other one is renovating our peak unit. We were able to go back and look through there. We also have negative pressure rooms installed in that. You can see that. Then one of the great things that we just did recently was we have emergency room expansion, which is basically we added 10 more ER rooms in there. And so these rooms are also negative pressure rooms in terms of that. So this is additional areas. Now we have 20 rooms in terms of the emergency ER in terms of that. Basically, the good thing is that we have 2 new trauma bays in there. We have negative pressure rooms in these areas. And then we also were able to go back into our dental department, renovate those areas in terms of it. A lot of it was basically dealing with negative pressure areas in terms of that. We also right now are working on upgrading our MRI project. Recently, we just removed the old building from that point on, so we're going to be completing that at the end of this basically October. So that's going to be coming in. It'll be a lot bigger in terms of it, as our funnel is a lot bigger. We can bring in patients that are larger patients. We can be able to be seen here before we were. Didn't matter because our funnel was too small, so now we're able to handle that in terms of that. The good thing about what we have is a modern project. As you know, we've been working with National Nation, which was basically currently with Kim Russell right now. We're working with Ms. Trudy in charge of that. So we're currently working with Pauline Herrera on this project. So she has a team put together, and we include special diabetes, HIV, and a number of them. So they're in this orange area right here. As you see this. That's where they're at. And the rest of it's pretty much ambulatory care that we'll be overseeing. We have a design team here. We have a engineering team as well as our architect team in terms of that we have in terms of. So this will be a 2-story facility. You got the bottom floor, the second area, you have the top floor in terms of that. That's pretty much what we have. We also working on housing projects. Currently, these are 48 housing units that we're currently working on. We are basically in the design phase of them right now, so this is what we're doing. As you noted earlier, that our issue is housing, but we're taking some initiative for those areas. We'd be able to provide staffing as well. One of the big areas that we're looking at, as you know, we've seen all the PR on this, the long-term care. We're actually in the process of revaluing those areas, and so it's a three-story facility. And you can see the cafeteria and rehab on the bottom. You see the second floor, which is 60 beds, assisted living, which we actually call long-term care. And then the third floor is going to be the oncology, and then also we do have a private one, but this is a friend that we're going to put on there. That's also going to include 30 skilled living units, so we're able to provide care for I guess our people here in terms of residents, in and out, apartments and flats out in other areas. So we have that care. So one of the biggest things that we're actually working on right now is a vision for a new hospital. So this is something we've been pushing for a number of years. So this is the conceptual view of what it looks like in terms of, so we are putting our information together and submitting that to the federal government to consider to replace our facility as well. I'd say.
So, in time will allow. Okay. So in time, I would like our CFO to present a few of her slides.
Thank you. Let's go to the next one, since we've got 2 minutes. So from a financial standpoint of the organization, a couple of good things to share. The organization has historically received unqualified audit opinions, which means a clean opinion, in other words. Our fiscal year will end in September. So when we do the audit in spring, we are expecting a clean opinion at that point in time. This organization is very fortunate in that we have a very strong cash and investments position. We currently have quite a number of days beyond industry standards for the organization. So much of the things that we saw with the pandemic relief has been very positive and helped bring the organization to a stable position. We also have a variety of challenges with our EHR. We moved to the new system in 2017, and as all organizations, we continue to chip away at that. And I'm proud to say that the organization brought their unbilled receivables, which is getting the bill out to the insurance company, down substantially over the year. We do have a target of getting to 10 days, which I hope to achieve this upcoming year. And then lastly, the organization is very deep into the negotiations with IHS for our multi-year funding agreement, and looking at every thing that we can do to optimize the funding that we receive from IHS. That funding agreement will be a 5-year agreement that will become effective October 1st, and we're in the final stages of negotiation with that. Many organizations have a lot of questions about what the revenue looks like for
That's fine.
Oh, that's all.
But with colleagues, I understand there's still a lot of significant information. We're probably roughly about halfway. Some are proposed 15 minutes. If there's no opposition, you may proceed, colleagues. Okay, Carolyn.
All right. Thank you for revenue for the organization, which is what you care a great deal about as a healthcare entity. We are predominantly a government payers mix. So Medicare and Medicaid make up the bulk of our payers. Those are the individuals that are paying the outside claims. We do have a little bit of commercial with Blue Cross and some other organizations, but as you can see, outside of our claims payment, it is heavily IHS funded. So all organizations face challenges, and in the finance space, we have challenges like anyone else. So you've heard my colleagues speak to short staffing. We do have short staffing going on in the finance space. We do recognize that puts us in a situation that we're providing minimal services to our peers. So we do have some plans around our workforce strategy, which does involve looking at opening our doors up to recruit staff that are remote. So taking advantage of our technology, and then also looking for some automation opportunities so that we can automate some of the very menial tasks that happen in very detailed tasks, so that we can free our people up to do more critical reasoning tasks as we step into the future. And as always, we're looking to optimize our EHR so that it is more complementary to our workflows of the organization.
Let's move to this, sorry, I was on the community trustees.
All right, good morning again, everybody. So for our oversight that we report to the Office of National Labor Relations, I provided a slide in here with the stats of our current percentage of Navajos. Hopi's and San Juan Southern Paiutes that are included in our tier 1 GDP. So we are currently at 77%. And uniquely, our board adopted a resolution in November of 2021 to include in the tier 1 grouping, Hopi's and San Juan Southern Paiutes with our Navajo count. Also in the next slide is our number of hires. We went over that, sorry. Go ahead. So the next slide, we also have other existing partnerships with colleges, Gwinnett College for our certified medical assistant program, Northern Arizona University for our American Indian nursing program. And then also with most recently with the North Country Healthcare and Flagstaff to create pretty much starter programs for high school students to use to get the ideas of being a healthcare worker in their minds so that they can eventually come work for us. Understanding that, you know, there is a huge financial cost and burden for students to pay rent, utilities, and tuition when they do go far off Navajo to obtain their credentials. So we did adopt the exploration program. And then also, that was a slide before, this is a couple of pictures of our Sims lab and all of the programs that we offer here on campus. We try to get our youth involved in higher education and also eventually healthcare careers. Next slide. And then with that, with the Arizona State, we have grant programs that we have adopted. Certified pharmacy technician program that has really lifted off into cohort number 6 right now. So what we do with that is we offer free education to students that meet the criteria, participate in the 12-week program, and eventually we want them to obtain their training license for being a certified pharmacy technician. And then also with the pharmacy division, medical billing, medical coding program, and then with the IT program, the service desk representative program. So we offer them the training and the skills and abilities to get their foot in the door so they can eventually become employees of the corporation. Next slide. Oh, and then also we are we partner with the University of Arizona. A lot of our medical staff work or have gone through the U of A. So we also have an existing program with them for our medical residents and students through that program. And then this is another picture of our cohort number 6 that recently completed their education to become trainees. So hopefully they'll pass their exam and then eventually become certified technicians. And then, as CEO mentioned, we do have our mentorship program internally, where we really want to grow our own and give our opportunities to the employees internally so that they become senior leaders, directors, managers, and executives that will help lead our corporation. Thank you.
So I'm ready to determine the clinical, so I'm seeing them.
We're done for time here, so we'll talk about a couple of highlights from our so one of our new services that we're providing you here at the city is the integration of primary care and mental health visits during their first visit. So this is during the in-person visit, during the same visit. So piloted at the GE Health Clinic initially, now made available at our main campus since July. Twice a week, we have telemedicine mental health visits that are available to the patients that are here in person or their primary care provider. And that's one of the innovations that we'll be really quite proud of. Next slide, please. To give you an update on information about our public health response structure. So we have a unique epidemic response team. Since the beginning of March, the beginning of the pandemic, we had COVID drive-up testing with vaccination. A public health department was created in July of 2020, right at the onset of the pandemic. And now that we are shifting away from the pandemic, we are utilizing these resources to really meet the community where the needs are, and we're pivoting to a public health services clinic. This is going to be an indoor location. Currently, we're temporarily located in some of the previous emergency room annex area. And in addition to continuing testing for COVID as well as vaccination, we're expanding services actually this week that will include STI testing and treatments. Again, we know that there's across the country and certainly across our nation, there's an increase in sexually transmitted infections. And we are pivoting to test and treat for those in this public health clinic setting, as opposed to having patients have to go to the emergency room or wait for an appointment to go to see a primary care doctor. As we continue to expand, we're going to grow into other public health issues that are of concern to the community, including diabetes screening, weight screening, blood pressure screening, etc. Next slide, please. This is more about public health and all of the work that the public health team has been doing ongoing through the pandemic and beyond that. And we can go ahead and go to the next slide. Just an update, the community messaging has been consistent. Everyone 6 months and older should get an up-to-date COVID vaccine. We have done numerous, in addition to the public health clinic, we've done numerous themed events to encourage the community to come and get vaccinated for COVID. And I anticipate that we'll be doing more of those as the requirement for a new updated booster comes next within the next month or two. A little bit of information on the syphilis outbreak. There's been a more than 5-time increase in syphilis cases since 2019, including among women of childbearing age. In 2022, there were 20 cases of syphilis in pregnant women to the city, with a couple of poor outcomes. Frequently, these folks come in already, have the infection, have not had adequate prenatal care and come in at the time of delivery. So there are numerous risk factors in the community. We've implemented the IHS recommendations for annual STD testing for ages 13 to 64, more often if higher risk. Testing at the first prenatal visit, early in the third trimester, and delivery for all pregnant individuals. We've also implemented express STI testing, which is basically a golden ticket testing. People can walk in without having to have a provider visit or order. If they have symptoms or known contacts, they can be referred. And case management follow up in the community to make sure that folks that are tested or test positive actually follow through and receive the treatment that is necessary. Next, please. Just some information on hantavirus. There have been 10 cases on Navajo Nation, 5 in Arizona, and 5 in New Mexico. We talk about symptoms that can be like flu or COVID-like symptoms. And we've done a lot of community information, community messaging on that as well. Next, please. That's all I have.
Andy.
Thank you.
I had put a organizational chart there so you can look and see how we are diverse to our division. It's nursing highlights. Joette said we had our trauma recertification. We're up for recertification at the end of the year. We have a SANE SART program. We are expanding our gynecology program. Our obstetrical services and nursery just passed their level 2 perinatal certification. We have 32 beds for acute care, 8 beds for intensive care, and 8 beds for pediatrics and 6 surgeries. Yes, right. These are our challenges. The biggest one is our vacancy rate. We have a 39% vacancy rate here at the hospital. Factors include that we have high demand, high reward for travel oriented opportunities, post-COVID-19 burnout, lack of RN graduate opportunities, moral distress brought on by COVID-19 pandemic, stress, burnout, and retirements,
Addressing these issues is a top priority for myself and the Chief Human Resources Officer. We are looking at different ways of recruiting. Next slide.
Very quickly, our chief quality officer couldn't be here, but I wanted to cover a couple of her things that she's doing. Our chief quality officer really helps in organizing our efforts and readiness for the commission and all the accreditation programs we already talked about. She also is over case management, and so we do a lot of care coordination throughout the organization. But I want to highlight a few things that we are working on right now. One of the things about our hospitals, we're currently a 2-star. We are working towards my goal is to get our organization to 5-star. To become a 5-star organization. It would take a number of years, but we're working on that path to get things improved. And a lot of it's around quality and reporting. And so our chief quality officer is organizing that effort as we do more education, as we look to increase the patient experience, customer service for both staff and patients. Next slide. Part of that is our HCAHPS training. A lot of these things are publicly recorded, and so included here is a look at HCAHPS. It's our hospital. We can remember the active consumer. It's inpatient rating. We have an outside vendor that calls patients. We work with Press Navy. This is something that CMS requires, and it's how our patients rate our care. And so speaks a lot to nursing, physicians, discharge care coordination. And so this again is public recorded, and that is one of the 5 factors in our star rating that we're working to improve. Next slide. Again, aiming for that 5-star, we're doing a lot of efforts around education, reporting, Joint Commission readiness, as well as really increasing transparency inside the organization about what we're doing to help improve customer service and the patient experience across the organization, not just here, but all our sites. With time remaining, we can go over a little bit of the ancillary in just have a couple minutes.
For the ancillary division, it's comprised of 6 departments, including pharmacy, cardiopulmonary, radiology, physical rehab, laboratory, and telemedicine. So a lot of the ancillary departments help with diagnostic and therapeutic services, complementing the clinical services that we have here. For pharmacy, they have ambulatory inpatient, specialty oncology clinic, and satellite clinics. So some of the highlights, we do have mail order pharmacy that mails out medications to all 50 states within the US, and pharmacy clinics by pharmacist provided clinics that include anticoagulation, diabetes, and immunization. We also have, as Char mentioned, our pharmacy technician program. We're currently just had our 6th cohort graduate. Some challenges we have is housing for staffing. That helps with the recruitment and retention. We also have challenges along with finance with EHR and some of the integration systems that we're working with. Here's a slideshow of all the prescriptions we fill throughout Tuba City, Sacred Peaks, and Lachihi. So we do have quite a high volume. We also have physical rehab that provides their physical therapy, occupational therapy, and speech and language at all 3 campuses. They started, recently started adding PT and OT to Lachihi.
Yeah, I apologize for that, but through our discussions and our engagement here this morning, as you can see, I'm the only one out of the report, so we're okay with just kind of pursuing other comments and questions from my colleagues, and then we'll go through that. But thank you for the great information and for getting through a significant number of areas to the City Regional Health Care Corporation that can be allotted. So with that, we did have a first and a second. So colleagues, are there any questions or comments? Honorable Pope.
And give them another time because it's the reason I would do. So I have that's another 15 minutes to complete the then after that we can have that. All the staff here, partition time to the one on that agenda. Let's give them time to so they won't criticize the screen. Anyway, it happens, right?
So I would request the additional 15 minutes to complete this. It's good information.
Actually, Honorable Todd, I'll recognize that request. Colleagues, any objections?
20 minutes.
30 minutes, 59. CEO, Woodbridge.
15 minutes. We work at, some of it's repeated, and so I think we can do this in 15 minutes, we'll just kind of.
Actually, 18 minutes, well, first, with that, staff, we will complete another 15 minutes. Thank you for obliging us. You may proceed. Thank you.
So we recently started services at the Chi for physical rehab and occupational therapy. We've also implemented telemedicine services to provide some of the physical rehab services. We have a Sheena program at Sacred Peaks, and we do work with various schools to help educate on physical rehab initiatives. Some of the challenges we face are housing and staff retention. Here's a slide deck showing the amount of the volume of visits that we see for the physical rehab program.
Good morning again. I'm going to do a brief overview on the community health services and some of the programs that we offer. So one of the first programs that we have in our division is our language program. This encompasses the interpreters that we have in the organization, as well as the culture program that we offer. So these events and activities are provided for primarily for the employees throughout the organization. We lesson learned for the hours and being Zoom and by various traditional practitioners and cultural individuals for our organization. This is the team manager and two of our full-time employees. And so one of the programs, like I said, the interpreter program really has evolved over the last year and a half. There's a really strong focus now on customer service, primarily for our elders. And we've got a complete revamping of the program to really emphasize how important it is for our to have full-time interpreters so that they are available to help with the care of not physical care, but the for our elders are hospitalized or they are being seen at all the areas of the operation. One of the other programs that we offer is whenever we do a new facility or a new service is implemented, we bring in traditional healer to do dedication for that department or for that wing or for that new service. And so we feel like that's a really important aspect of the culture and language resource program. Also, one of the things that we're actively working on right now is the rehabilitation of our healing garden, and it's located right in the middle of our inpatient unit on the outside. And as you can see there, what it used to look like, and we're working really closely with our facilities department to make sure that the new healing garden is going to be a really nice place for patients and employees to go. This is a typical schedule for some of the other interpreters that we have throughout the organization. Now, this is not, the interpreters are hired full-time. These are employees that already have a job. They might be a CNA, or they might be a clerk in another part of the hospital, or located at Sacred Peaks, or at the Chi, or even on the mobile units. So we have interpreters all throughout the organization, and this is the calendar they utilize every week. And again, the focus for the improvement of our interpreter program is really to emphasize the interpretation services of our elders. Another program that we have is our mobile medical and our mobile medical, which is funded through the grant through the website, which we had since 2012. This is a photo of an older mobile medical units. We provide
And they took care of throughout the service area, all of our chapter locations and schemes. And this is a map of the areas that we cover. And on the photo on the left is our newest mobile unit, medical unit, and then the photo on the right is a renderings of our new dental unit that we'll be receiving hopefully at the end of this month or early September. I think we just go over this slide. I just want to bring your attention that we do have a VA clinic. We do partner with the VA Veteran Affairs, and they have a small clinic, and we've offered them space. And so that clinic is open Monday through Friday, except for Thursdays. And they staff that themselves. But in this partnership, we're able to provide the services for veterans here on our campus. They don't always have to go through the VA. Any veteran can be seen in any of our clinics, but this is just another opportunity for the veterans to be on, for the veterans administration to be on site and to provide outreach to veterans who might be interested. We're working on renewing an agreement with them. Our current agreement still is in effect. The VA has proposed a new agreement that we're working on right now. So that's just a couple pictures there, slide 89 and then slide 90. There's a couple pictures of the location of the clinic as well as the clinic space itself. I'm going to move on very quickly to our support services. Kyle Black, and I've been talking a little bit about capital, but I didn't.
Good morning again. Pat Black here with the Support Services Division. I think there's the division down to oversee here. As you can see, there's a lot of the support not only our representation, but also our staff as well as housing. Next slide. Support services, here's our this overview of our campus here into the city. As you see, it's a pretty large campus that not only includes our hospital, but also our housing area as well. Now, also noted our satellite sites there in the Shady Canyon and City Peaks and Patterson Independent Living Center. Here with our housing area, this particular area is located east of us. We have some more other units there for our staff. As Julie mentioned earlier, we're in the midst of designing some new housing areas that will also support housing for our staff. The image there on the left is for our Broadway Gap project. As you can see, it's also in middle design. Next slide. Also again here is really their long-term care rendered there with the size as well, including the size and our recent meeting expansion that we used to work. I'm from the Community Living Center. We have this program here. It's a Tootsy Regional Health Care also received in NHA. And what this program is we offer housing to elderly community members for Independent Living Center. They had a variety of 1 bedroom and 2 bedroom setups there out there in the community of Patterson. So we actually have four units, 6 units, 6 buildings. So 24.
Okay, good morning, guys. My name is Sean Davis. So pretty much we oversee the following departments for our clinical informatics team. So they're the team that oversees the EHR. So any type of optimization or new services that are being built into the EHR, that's the team that we go to get that all configured. We also have our infrastructure team, which oversees our all of the hardware such as servers, networking equipment, firewalls. So anything related to that is that team, including our help desk. We also have the applications team, so they oversee all the software that the full person has. So anything for upgrades, enhancements. So we also have that team there. We also oversee our biomedical team, so all the medical equipment that we have within the facility, they help us maintain VP and zoners equipment. Also try to get them tied into our EHR as well. So that's who we have the medical team. And then we have the call center. So pretty much all the calls coming into the facility, we have that team taking calls and also trying to assist with any type of appointments for scheduling and just trying to help them with the general basic questions that the patients might have as they come in. And we have also project management So we have that team also, but anything that's related to the organization, IT initiatives such as software. Or upgrades or enhancements, that's the team that helps us manage all of those projects that are coming in, then as well as security. So pretty much security is a big thing for everybody, including us, so you know, we've been doing a lot in getting our infrastructure. More secure as the several months that have gone by, so. Those are the various departments that we have under us, so here's just a org chart of how we are structured under each department there. Very basic. Again, like I mentioned, with the informatics team, anything dealing with the electronic health record is who we work with, so we just recently went through a version upgrade with the EHR. Usually an upgrade for the EHR is about 4 to 6 months in planning. So that's what we work with here. So every time we do a version upgrade, there's a lot of testing that needs to happen, so it's not just like your computer at home where you hit the Windows update and it's done. This is more involved, a lot of manpower put into these upgrades for the EHR. Next slide. So again, our infrastructure team, so they handle all the servers, so anything as equipment ages, this is a team that replaces a lot of that hardware. Also doing patching, version upgrades, so again, they're the team to do that, so go ahead, so this is pretty much repetitive. Again, our apps team, pretty much handling all the hospital application, our medical team, very basic. And then the call center team, which I went through earlier, very basic. And then PM, very basic. And then security, so pretty much a lot of our accomplishments here of what we've done with an organization. Same thing, a lot of the things that we've put in place with the organization. And then challenges, like everybody else, we are short-staffed. You know, a lot of things we've done too, like trying to help our staff is being more remote. How can we do things using technology? Housing is usually an issue. So again, the same issues that we heard earlier as well.
So in summary, I think pretty much it's got a highlight of all the divisions and accomplishments, some of the challenges we're facing. As you can tell, you know, we cover a lot of area between here and Chi and Sacred Peaks, and I think we're working really hard to work in the community and addressing their needs as they come up through our board of directors. I believe our team is very good at what they do. I think again, just with the challenges and trying to work through those challenges since COVID is what we've done well in the last year, and continue to look forward to expanding always on our mission, expanding services, becoming more culturally competent in our customer service, and always improving access to care for the community. So, and of course, before I close, we're looking towards becoming a 5-star organization. That is our goal. And so we're all very mindful of that and working toward roadmaps on how we can get there. And that's going to be over several years. I wish it could happen tomorrow, but those are processes that have to get improved, and new process and initiatives that you have to implement as we work towards that. So I'd like to just go ahead and turn the time and place to our president, Mr. Frank McCall.
Okay. Unexpected. We always work good with the estimates. The 2000 mid-90s, we went on a journey to go incorporate 638. We done well, we did well, we worked well with the council. You can't and I think we're going to explore the late Chelsea Brigade, so that council, for example. They estimate that, but they behandle straight on examining conditions to take their love. Por ido, yo no negros. Y por crédito. Me llego. Yo no paro a hizo poquito ahí y llego de los no their leadership we can also
2 seconds, anyone? I think, photo with, again, Ms. Walters, I don't know to all of your team, staff members, thank you for taking time out of a busy day. I know it's oftentimes we kind of want to push things along because you guys do provide direct services for our novel people. But thank you for being here this morning. I'll get a motion and a second, and then we'll go on to the questions for comments. Colleagues, motion. Motion by Honorable Helene Nancy, seconded by Honorable Curtis Gianito. With that, colleagues, questions, comments, Honorable Toth, yeah.
Good morning again. I guess your goal is to go higher. All I'm going to say to all of you is that especially board of directors and you have to stay within your limit. If you start really clear with the operation, you don't want that to happen. Because right now you went from IHS to 638. So that tells me, well, I agree with you, which direction you're going. That makes me happy because someday us natives go run this thing. So we don't have to rely on other, because our kids are going to these schools, doctors, nurses. I like to see that in the future, maybe next 20 years. This hospital life that we can do. So all I'm saying is take care of it. A lot of places they order the record gets into the administration, but there was chaos, you know. As long as you have that good attitude and so supporting your team, you're going to reach that too. So that's all I'm going to say to all of you. And again, this is a good program. And I came, I worked for IHS for 15 years. Start off with Phoenix, Gallup, back to Comanche and Lake Compton. And at least they gave me an extra 5 years. So they gave me 15 years. So I retired from them. I see them all from Phoenix all the way up to Compton. What goes on? We are personnel from the outsider. So there's a lot of problems that can be resolved by communicating and working together. So that's where I'm coming from. So I've seen it all, especially the turnover staff doctors like Compton. I retired from Compton. That was my last station. We always get the practitioner only. The doctor comes and they leave. I hope this is not happening out here. So 81 5.7. I call a lot of when we go to see a provider, they always say, "Who's your doctor?" It's outside the world, we have one doctor, but over here it's different. And another one comes in, or a practitioner will leave you. So if the practitioner has a question, they go to the doctor. That's how they work. So every patient that comes in, you know, you build them. They go to ER and build them. Then they go to X-ray, same thing. So the money goes up. That's where you need to explain to your people, especially when we have Medicaid and all that. You know, 3,000. So, so I appreciate and I'm glad you guys went in the right direction. But here's some of the information I collected by listening to you. When is the last time you had your audit? Is it current? Okay, somebody mentioned staff, shortage on staff. Is it the doctor, nurses, or providers from amenities? The other one is housing plan of operation. When when a person lives in these housing, if they have an issue, when they grieve, when they go to the higher level, who takes care of it? Is it the board of director or administrator? That's what I like to know. Public education, you brought this up, okay, that's good. Remember, we're doing this for our community. You need to go out there and do second house, hospitals. Don't rely on your employees, your administrators to go out to the community. Ask them, how is the city regional hospital? They will give you feedback. Instead of sending your staff out there, administrators should go out there, not the board, okay? That has to be yourself, to promote and evaluate the hospital. Then you learn sort of pros and cons. The other one you mentioned here I'm a veteran, was 4 years in military, part of Vietnam, and right now I could serve in Marine Corps, and then you have a program for veterans. That's good. The United States government gives some money to the hospital. That's where the veteran comes in and they identify themselves, that reimbursement. Stage 8 is there in place now. I'd like to know that because in conflict with me. So I know Gallup, so okay, another one. I don't see a whole gone for patient. Patient, not God, no. Who do you utilize? See, in Cromwell, you have a small, in certain areas, we have small treatment. It'll die if a patient wants medicine, I have to come into the room. So concerned. The other one I always see is elderly being brought into the hospital. A lot of times our kids, young kids, they just drop off elderly at the hospital. They forget it. So the doctor or the nurse decision is to take them to the home care elderly. I've done that. Transportation to other care. Elderly ability on the year. And poor ladies, they don't want to go to. And you say happy now, I don't know. So and I know in Crown Point and other areas, they just leave their elderly and they'll come back and pick them up. So those are some issues. So maybe they have to auto patient attitude. Patient. I don't know if you brought that up here, but that is to where a patient doesn't like the care being provided by the hospital. You will have a patient applicant to, look into these matters. The other one is drill. Is asking for it. I know it's going to happen someday. When I have a plane flying over the crash, or a vehicle, the mess, injuries, and all that. Patient document. Auto plan operation, beginning we'll look into it. And hopefully
After that, we can come back and meet if we have to, so. Ini nanti deh, kita lihat apa. 1995 up to 03, I was also a councilman. I spent with, 88 and, ethics and rules, I reviewed it. We don't need no to the Watson, don't you, I know, see. That was like. Your chair, but it's usually lounge and down. He's a homeless figure. You guys should be proud of that. So, yeah. Go in the street. Leo, Yeshina, and then Kelsey K, I served with him. And he was part of Vietnam. I know Mr. Daisy, Joe Daisy, about CJ. It's new that the year I was going to. I just wanted to say thank you to all of you for inviting us. And for those who are here, back in the California, to report, I appreciate all your staff. Okay, thank you.
Because, yeah, Honorable Toll, I agree. She, Yoshima, Honorable Vice Chair Simonson, already indicated on the format to this discussion.
Thank you. Good morning, afternoon. Although I'm on stage, so if that happens, I'll get me that was fortunate. Although, it's the, Pahashi, so got they not made, so in that, Ahashi, kitchen, that we stay home. Actually, in kitchen, shut that off. Aroka is the Orthodox Indo Ahashi, so she a not be taught sometimes it makes me sad. I think I visited San Carlos healthcare facility a little over a month ago, brand new facility, beautiful. But it makes me sad at the same time because I wish it was another building for other service. Something positive, something good. And again, this case is they in need that's the needs not that we know about that we know. It just to me, the bottom line, the reality, it means our people are sick and they're not doing well physically. That makes me sad. And I think what if there were more reports of on Jungle needs general and us in general, and then general the after yeah, he home that didn't get the back. No, you know, I just think about how do we get back to that point in time, you know, when we're you know, really looking at and doing more of those, really promoting and where our people in it are in a different you know, health status. And so on one hand, it's a, you know, really good thing, you know, to have a healthcare facility and to have, you know, upgraded and new equipment. I'm sure those are changing all the time, very expensive. And so those are just my thoughts every time I come, you know, upon a healthcare facility, as I listen, not just here on locally here, not only here locally on our Navajo, but when we participate in our DSAC, you know, meetings out in the federal level. And over there, it's pretty much the same thing. All of these, you know, tribes, we sit around a table like this, and everybody is just talking about the need for more, bigger healthcare facilities and more, up to date, medical equipment and unfortunately, a lot of tribes right now, and I don't know what it's like here on Navajo. And I didn't hear that in any of your reporting is, a lot of other tribes are really experiencing a high level of of fentanyl abuse by their tribal members. And that seems to be something that the tribes are really battling, other tribes. And I don't know what those numbers look like here on Navajo. So when we were at the latest budget, tribal budget formulation meeting, and I was hearing from other tribes, they were really, that was their number one priority was, we need more services, more care, because a lot of our people are dying from fentanyl overdose. And so that was really, difficult to hear. But it just be, good for us to hear what you're experiencing in terms of those, the prevalence of that here in Tuba City. Also, when I was at San Carlos, again, it was really unfortunate and sad to hear that for them, their highest, health issue, the biggest health issue, the biggest issue for them is their young men before the age of 40, having done some of them dying from or living with complications with cirrhosis of the liver, and that's before the age of 40. And I don't know what those, what our numbers here look like on Navajo. And again, that would be something that, beyond you reported kind of primarily on STI and what that looks like. And I heard that before through some of your public outreach, which I really think is important. And I kind of feel like, and you all can correct me if I'm wrong, colleagues, is that I feel like you're really one of the only and maybe the first hospitals who's reporting that issue among our Navajo communities. And I don't really hear that too much from, First Alliance or, Gallup or Chinle, but I know you're really, trying to educate community and you're trying to get people coming in to get tested. So I commend you for that. I'm sure that it might be that it's probably difficult to talk about. I've not heard your presentation in Navajo, not too much, but I'm just, wondering how you're conveying that message in our language. And so that's something, I'd like to know more about. So I just, heard about your flat rate for pharmacy. It would be real helpful. I know we have the 638 and the direct service tribes, so the IHS hospitals, and everybody's needs are different. And so I think if we have really good communication with our 638 hospitals and real time, situations, real time stories that you can help us with, we could be better advocates when we go to Washington and we're trying to advocate for, dollars and where the needs are. Just a little bit of, education. When we get to DC, we're in a room with, tribes from all over the country, Alaska, Hawaii, and everybody's needs are different. And so we're all trying to outdo one another about why our needs should be more of a priority. And so everybody's needs that come together. And if, more than a certain number of tribes are indicating one thing consistently, that becomes the priority. And so one of your most critical needs, because you're in a rural area, and so maybe something really different from everybody else, it's going to land at the bottom of the list, because there are not enough tribes having the same issue. So it's kind of like they take the top, tier of everybody's concern, and that's the one that gets addressed. So it'd be really helpful from the healthcare facility here, whether it comes, from you collectively as a board and as your administrators, that you give us, you know, kind of a real, it's just a one pager, not a book. Unfortunately, we don't have that kind of time, but if you could really give us some good information that we can take, and when we, you know, meet with people like our in a relative up there who's in the highest position of leadership, Ms. Rockland. So, you know, we have those conversations and we can talk about some of the needs that you have here. I didn't hear too much, you know, I know you covered this overall administration, but I know that dental care is usually a really big issue. And it's just unfortunate how difficult, and I don't know lately what, you know, how your facility is here, how difficult it is to get in for dental care. And there are times that I remember, this is several years back, we sent people, I mean, I have to send relatives here like at 6 a.m. you basically have to camp out, you know, in front of the hospital to try to get in. And when that could really be a service that serves, I mean, it could provide real prevention, that kind of, you hear about other, cultures, and dental care is really kind of a primary prevention to other things. And so, like Chinese medicine, other people, they really care. That is their priority, what is happening. And that could be an indicator, that could be a gateway to other issues, bigger issues that could come. So we could really, 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 improve dental care and even just prevention at a very young age. I think that would be, could prevent other things, in the future. So that, being one thing, I didn't hear too much about, your mental behavioral health, clinic and service. Last week, we were in Gallup and we were talking about the need for, just more services with our schools, because as tests, we also, we also look at any matters and concerns with education all across the Navajo Nation. So we were in Gallup, and now the nation is having to create a task force now to look just at school safety because of all the concerns that are happening all throughout our communities. But in addition to that, my, recommendation from last week is not only are we concerned about school safety, now it's community safety with what you see happening at our chapter houses. And really, I think the bigger picture to look at there is just mental behavioral health. We were forewarned by a lot of, mental behavioral health experts that mental health, we were going to be experiencing a mental health epidemic after, right along with COVID, towards the end of COVID, or whether you want to call it, I don't know that it's over. Somebody, you just mentioned that there's still COVID out there. So we were forewarned that the coming, there's going to be mental health epidemic. And how are we prepared for that? How are we addressing that? And we hear, over and over, the loss that our people experience, that they didn't properly mourn their loved ones, and they didn't get to go through the whole, burial process. And it was very rushed, it was very limited, and people didn't really take the time to, accept and, deal with the grief that came along with that. So what are we doing in terms of mental behavioral health? I didn't hear too much about your special diabetes prevention programs. And then also, like Mr. Tolk mentioned here, I'm very much, I really do appreciate Native Health, our practitioners programs. I don't know, if you have a clinic specifically for Native Health. And I think those are really important. Again, I'm familiar with, kind of the Chinle operations. They have some really good Native Health traditional practitioner programs. And when I was in San Carlos, this also goes along the line of naturopathic medicines. So I don't know if you do like acupunctures here, acupressure, any of those things. And in San Carlos, they were telling me that that clinic is always booked. And that is the highest, like, the people who come to that clinic, they have the highest, rate of, people, coming to that appointment. So they don't really experience, like a breaking of appointment or a no-show for those clinics. That everybody who is, gets booked for acupuncture or whatever, they all show up all the time, all day. So, and that sounds to me like other clinics might be experiencing a lot of no-shows, but that is the one clinic that is very consistent. So that just goes, to me, that demonstrates that people are still looking for that naturopathic care and medicine. And I'm more than certain, it's that way here in our communities as well. And so just staff housing, I was there when Pinon Clinic opened and the houses were built, and I actually 1 year lived in one of them. Very energy inefficient. The houses for the doctors were not interested in big houses. Somebody had this great idea that doctors like big houses, when doctors basically have homes elsewhere and they're paying for homes elsewhere. They just want to come, do their service, provide their service. It could be a small thing and it could be, that should be energy efficient. They just want to come, they're just, they're some come with families, they're invested in the community, but you also have to think about their money. They want to spend their money wisely. And if they're going to pay into a home, they want it, they definitely want probably some, for it to be worth something. If they could buy it and could, and they could sell it at the end, they wouldn't mind putting that kind of money into it. But this is basically just a rental. So, and when I just always think that, do people think about those things when you're building these homes for doctors and you want them to come? They just want something they're going to be in for the week, and that's it, because they have homes and elsewhere. I think so. In going back to San Carlos again, they were really utilizing the new tech market credits, and that's how they built their facility. And I'm wondering, I know that on Navajo, we're just not doing that. We're not using those new tax market credits to build anything. And I think in NTUA headquarters and for compliance, that's the only example we have here on Navajo where they've used that. And so that's how the nations are building things, how other nations are building things. That's how they're building homes. That's how they're building. We have 3 tribes here in Arizona who have used the new tax housing market credits like numerous times over. And here we are, just for an example, last month, we were trying to use 100% of our own Navajo Nation funds to buy some property in Gouldy. And when, in the business world, all over the world, people don't use their own money to buy anything. They use other people's money. And so we really need to embrace that, take advantage of that, and start doing things that way. So I don't know if you have within your healthcare facility, if you have somebody there, somebody here who's really knowledgeable of how to use those tax credits and to use it to build infrastructure. So those are the only things. And then, pharmacy is always a big issue across Navajo. How long are people waiting for pharmacy? Again, just for, just to see how other tribes are doing. I asked San Carlos, and basically, I don't think it was more than an hour. It said that people wait for pharmacy, no more than an hour. So I'm just wondering what that rate is here and how, folks are coming together to try to resolve that, or if that is an issue, how are you trying to resolve it and trying to ensure that people are not waiting, too long for pharmacy. So those are the extent of my questions. Maybe I'll follow up.
Yeah, Honorable Vice Chair and colleagues, if any of your questions or comments are not either addressed or answered, feel free to just note it so that our second series of questions and comments, you can request for a follow-up. So with that, Ms. Falkridge, I'll allow you and your team to respond And team members, if the officers call upon you, just for the record, state your name again, and then just any other questions or comments as well.
Thank you, I appreciate these comments and questions, a number of them we can answer today and give you that information. I'm gonna start with the first question is about the last time we had an audit, so I'm not sure, I don't recall if you're referring to the audit of Malformation. We do have the financial audits done every year, and our CFO mentioned, we've had, those good audits and we've been in good standing on those audits financially. Drug commission surveys and accreditations, those audits are current. Will you referencing the national audit, not the show?
Hospital itself.
Okay, drug commission, it's in the, we're not gonna provide it. We did those this year, last year, surveyed earlier this year, so we just got the certificate. It will be in that loop as well, so drug commission for hospital, home health being lab accreditation and patient center for audits and doctors. The next question was about staff shortage, and the shortage we're seeing, we have some provider shortages. I don't have the numbers. I'm gonna look towards Shar, she has numbers, but the shortage that we're really seeing is the probably the front line folks. Patient register, patient registration, client, customer service, they're the kind of the front line. We're also seeing a lot in nursing, and then the techs like pharmacy, pharmacists, and a lot of the IT. The providers we're not seeing as big as a turnover as we're seeing the others. That doesn't mean we don't have a shortage there. The shortages for the providers, we're getting more people from primary care providers. It's like the more of the specialized services, oncology. And so I'm gonna ask her, can you expand on that a little bit more for me? Our chief.
Okay, so, as Theodore mentioned, our vacancy rate for nurses. Okay, sorry, I'll be, chief HR officer. She had mentioned that our vacancy rate is 39% for our RNs. So that's encompassing our inpatient units in our ER. So nationwide, that's what we're facing as far as vacancy rates. So once we do get nurses here, they normally stay for 2 years and then they go somewhere else. And then with the pandemic, we're facing the issue of how we are going to retain them if they go to a contractor. The contractors' rates have been skyrocketing since the pandemic, so we're trying to leverage that and bring that down. But as far as the provider rate, I can't recall that off the top of my head, but our providers, our medical staff, CMO, they've walked out, but they really like working here into the city. And I think we probably have the best medical staff in the western area here. A lot of them moonlight to fight staff in here into the city. But speaking of providers specifically, Dr. Diana, Dr. Stephen Holby, they were my pediatricians when I was a child here. And now they're slowly moving to retirement. But they've got people that they've hired, doctors that know doctors that have come here to the city and served for us in medical staff capacity. But that, mid-levels all the way to med staff that work here. But I think with our CMO here, he's our great leader that has worked with HR to collaboratively recruit and retain medical staff, and then also mid-levels within our corporation.
I was just sharing that it's the nursing side, the frontline side, all those special providers that you're needing.
So, thank you again for the opportunity. So I'm the chief medical officer. I would say that our physician and advanced practice provider retention is also a challenge. Not so much as the nursing. I think the nursing is the overriding challenge. We tend to do pretty well in primary care in terms of recruiting. We have some challenges in our specialty care services, such as or subspecialties such as surgical, orthopedics, radiology. Our subspecialty care, the vacancies remain open for a longer period of time, and we find ourselves using contractors and locums, which are more expensive for the organization and also not really what we want to do for long term. We want people who are coming to be long term, to be invested in the community, etc. So we are working very closely with HR and with our department chiefs to try to improve our ability to recruit specialists. Where we have more limitations is more on the frontline staff. So, you know, a member raised a concern about dental. We do have some challenges in recruiting dental providers, in particular right now, say with pediatric dentists. But we have like a 40 to 50% vacancy rate in dental assistants. And one of the programs, I don't recall if you spoke about it, or not, we have a scholarship program that was proposed by our chief of the dental department last year and developed with our colleagues from the HR to have a scholarship program where we have some folks that are training down in the school in Phoenix and should be serving as a pipeline to come back and work here. So that's one of the innovative ways that we're trying to address that effort. But those are the challenges on the front line levels, getting people for recruitment, getting people to be able to stay here. Challenges of housing, even for those folks as well. We of course have challenges with housing available for our physicians, but we don't have housing available for our frontline people that are frequently coming from distances to provide the care. So they turn over, say. I'm not sure if there was any question that I can address.
Our next question is about housing operations, and I think we'll have Mr. Young for the
Good morning again, Julius Young, second Chief Operating Officer. As far as housing, as far as operation, as you know, our funding agreement with the IHS basically gives the control plan and oversight of the housing right now. So we do have a housing policy that we follow. And the housing policy basically not just goes through, you know, the living conditions in terms of TED and all that. It also includes a tier, which we call tier 1 and tier 2. Tier 1 is pretty much the providers like the nurses and the physicians in terms of that. That's the qualification in terms of that. Then we also have a tier 2, which is geared toward more of our radiology techs, ER, scrub techs and all that. And then we have anyone that's on call. We basically consider those in terms of housing in terms of that. So we have that process in terms of, I believe, Honorable had mentioned that is this under the Board of Directors of Administration? Actually, it's under administration. We oversee that in terms of we have a housing committee. So ideally, when a new employee or an existing employee is asking for housing, they submit an application and it goes to the housing committee. They review that and they go through the policy. If they meet those tier areas, then we then put them on the housing assignment. Then there's the approval process, and then we notify the tenant or the applicant that they qualify for housing. Then we give them the information, including the housing policy, and then we go through the deposits and the payment process and all that.
There was a question about community assessment. We've not done a community assessment in the sense that you're referring to on the talk about how, you know, going out to the community and surveying them to see about our services. We do a community survey, community needs survey assessment every 3 years. Actually, Dallas Moore came in to speak to that rep, and it's on the link. So, yeah.
Good morning again. I'm Alice Walker, Community Health Division Chief, and I oversee the community health arm of the services here. And every 3 years, we are required by CMS, HRSA, and the IRS to conduct a community health and needs survey of the entire chapters and all of our service area. So that's something we do. The last one we did was in 2021, so we're in the process of doing one in 2025.
And then you're concerned about the VA and reimbursement. We do have an agreement, currently agreement with VA, and we do get reimbursed if a veteran comes in and receives services. So the hospital does get reimbursed. The VA is proposing and has presented us with a new agreement, and we're working through that process.
I'm gonna move back over to Dolly to talk about professional services.
Part of the, we do have a program there. It's in the healing garden. So it's right in between the inpatient units, so patients are able to go out and use that home for services. Our culture and language resource manager, she knows, she has a list of all, as many of the practitioners in our area that she can put together. With all the different types of ceremonies that they do. I bet she coordinates that with the patient and the practitioner who do the services in the home. If the family doesn't have a program of their own or place to have the first ceremony, so that's available as well as it's available for staff as well.
There's a question about elderly care. We do unfortunately see families that bring their elderly here, but our care coordination program, our case managers, they really work with the families to try to get them services. So we do see that on occasion where families bring their elderly here and they don't have resources, but with working with the family, we try to either, if it's the patient's will, we can't take someone against their will to anything, to anywhere they, but we work with the families, try to get the services they need. If they need to get long-term care services, because we don't have one here, getting them set up with Altex Arizona long-term care, helping them through that process so they can get if they need long-term nursing care. So our case managers are really involved with that process. And that was again, the reason we wanted to see long-term care built here, because we are sending those patients out. There is a need for that care. Along with, we're seeing a lot of dementia type cases, and so families just don't have the local resources here to provide that care for their family members, and so that's the reason we're really looking at getting long-term care. Yeah, so let's talk about patient advocate. I did include slide set and I failed to. I just realized that from our compliance officer. I'm going to ask Alvina to she can talk a little about patient advocate in that process.
Alvina Cheney Patterson, Chief Compliance Officer. I do oversee the compliance program as well as the risk management program for the organization. We hired a new patient advocate in March of this year, and she's been going back and making sure that we're following all the requirements for CMS and Joint Commission. And I think that there's two categories for patient advocate to follow: your patient complaints and then your grievances. So we changed the processes of how we're meeting with the patients. We're making it more accessible. And what we're doing is we're making sure we're following what CMS and Joint Commission requires us. She goes to all of the satellite clinics at least once a month to make sure that they too are involved in the changes relative to our patient advocacy.
Also, then to question about disaster and what we're doing. I'm going to ask Mr. Elwatt to speak on that.
Yeah, so as far as that disaster drills, we have various I'd like the support services officer. For disaster drills, we go over several of that disaster drills throughout the year. We do training on different codes, code greens. It can be either weather related, it can be code silver, as you may hear from time to time. We have community events where it involves active shooters. So there are different training that we have some experience to feel like that in our communities where we have a response for this type of disaster drills. So in addition to that, we also have our safety officer who does what we refer to as a hazard vulnerability assessment. We go through various scenarios of probabilities of different types of events and plan on those types of events as well.
Moving on, talked about you did what kind of operations policy you're interested in. You have any questions after you receive that? You mentioned that you'd like to see that. I'm going to move on to the second question because it is an important one. I'm going to ask Dr. Rihanna to explain and to talk a little bit about that.
Sure.
So, definitely substance abuse is an issue. And I think we discussed the front of that, we also talked about a little bit about alcohol abuse. So a couple of things we do have. We participated in the Navajo Nation opioid grant program to establish, develop and establish a medication assisted treatment program. So we do have a medication assisted treatment program that involves both folks in our mental health, in our mental health department, as well as emergency department and primary care providers. This is actually led by our family medicine physician, who is a medical director at our Sacred Peace in Black staff, and that is a program that involves the distribution of medication of naloxone, for instance, and also of distribution of medication buprenorphine, which is to help people overcome their dependence and addiction on opioids. As far as fentanyl, I don't have an idea of the numbers. I know that our emergency room physicians and as far as are seeing some of this. We have recently enhanced our laboratory capability of testing for fentanyl and for other derivatives as part of our drug screen when they come into the emergency department. I guess on the other thing, on the behavioral health side, we have added in the last, I believe the last year and a half, we have a substance use counselor position that we have brought in that works in our mental health department, focusing on those individuals. I think there's always more that we can do, and we are striving to do that. We do have a lot of interest from our physicians across specialties in providing appropriate care for these individuals, continuing care and keeping them out of the emergency room in the hospital. Alcohol. I would say similar. I think we have as part of our mental health program, we do see in the emergency room a lot of individuals who come in with evidence of cirrhosis or other complication of alcohol use. I think we do work in a multidisciplinary fashion to help provide care for those. We do have Alcoholics Anonymous meetings available on the campus, and it is something that we are acutely aware of and working on. I don't have any other specific information about that.
Thank you. There was a question also about pharmacy. Who has to tell you to like the wait times and some of those things?
So
Your
for,
name?
my name's Natalia Natofli, Chief Ancillary Officer. So for pharmacy, we do offer 24/7 services here at our main campus. We also have a drive-up clinic in Lachey for easier access to pharmacy services. And we're currently in the process of looking at that metric of what our turnaround times are. I believe we are close to an hour for verification of pharmacy prescriptions. And we're still in the process of doing a performance improvement project to help validate those numbers to make sure that we're continually looking to push the mark of how readily available our services are for pharmacy. One of the things that helps with the time frame for pharmacy services is our mail order, getting patients on a regular routine of receiving mail order for pharmacy prescriptions. They do receive a 3-month supply for most medications that they do have. So it's part of our quality improvement initiative in pharmacy. So that is a metric that we continually look at, as well as on our outpatient and as well as on our inpatient side.
There was also a comment made about real-time stories and getting that information to you. I really appreciate that. opportunity to do that, because I think that would really be helpful for us too, as you advocate in DC or any of the other stakeholders that we work with. The CMS proposal is an example I'd like to give you more education on, so we can move forward and work there. I think another opportunity is working with our 638 association. I'll ask Mr. Curley to talk a little bit about that as another avenue in which we can collaborate and really become familiar with the issues that we're having. And you had already alluded to or mentioned that we have, you know, every service unit, every tribe has very unique issues. And so ours are just as unique, and as we expand services and really move into a specialty care model, those things are becoming more challenging for us because our reimbursement is at a flat rate. And IHS and tribes get paid that flat rate. But when it was never really designed to provide that specialty rate and specialty medication, specialty care, those advanced practitioners, we have to pay a lot to have those services here, but the need is there, with gastroenterology, cardiology. I mean, we're having to send those patients out. We are fortunate to do oncology, but again, the reimbursement rate really hinders us from even adding more therapies in oncology.
Yes, thank you, Tanaka. Christopher Curley, to the City Regional Healthcare Board President. And also, I'm also the president of the 638 Association. We have a 9-member board there. And we're going to have our annual meeting next week on the 28th and 29th. So I believe an invitation was sent out to the oversight committee. Well, AIGK, what we do is we meet together we have a board comprised of board presidents and CEO. And we meet quarterly, but we've been meeting more recently on how to provide better advocacy across the Navajo. Also includes San Carlos Apache Health Center. They're part of our association as well as the Mexico Satellites, which is the RAMA, famous Seafood Band of Navajos in Alabama. We have Wednesday to the city, Utah Navajo, and Tehoto Medical City. So based on that, we come together and talk about, I would say, common issues that we come across, and we utilize each other's expertise, the partners, to be able to advocate together. We end up utilizing each other's expertise. CEOs have questions, CFOs, so we're able to advocate towards a lot of issues in that way. And our newest member is the Chinle Nursing Home, Navajo Nursing Incorporated. They don't keep Wayne Paul and his group for better advocacy out there. I know that they're working with elderly, and they're going to get a new veterans long-term care. So we're talking about getting our long-term care here to the city, so there will be a great benefit to what we do and how we advocate, and being able to work with our council delegate, honorable council delegate, so Mashima Spigay, and also Casey Johnson, that's ND council delegates in our area. We come together and now we give them the information from the top under those under our association.
Continuing on to the question, the one on mental health and behavioral health services. Again, that was an oversight on my part, and not including those programs, but we do have a mental health program, very busy mental health clinic with our HRSA grant. And we talked a little about mobile medical and mobile dental. We are also able to add through that grant the capability for behavioral health counseling. And so I'll always speak to that a little bit, but that's separate from the hospital and sets up that's our HRSA grant. And then also, we've always done telemedicine for the schools. I think that's one of the things that has been really a real good plus, the advantageous for our students. We have clinics in the 2 local high schools, the Gray Hills High School and the public high school. It operates every day. The students don't have to come here for care. They just go to the clinic there with cooperation with the school nurse and our staff. We also add telemedicine counseling through telemedicine For the students, again, they don't have to it doesn't disrupt their school day, they have to come here, they just go to the school nurse office, again, it's a collaboration with the schools and us. I want to ask Dolly to speak a little bit about behavioral health, but then also if you want to add some more on special diabetes, because that was also a question.
Hello again, Dolly Slash, Community Health Division Chief. So one of the programs that we offer through our division is, again, the first funded mobile health program, which is mobile medical and mobile dental. And so, but in addition to that, we are able to contract with NACA, Native Americans for Community Action and Lifestyle, or counseling services that they provide here on site. The counselors come from NACA, but through an MOA with them, we're able to provide services for our patients here into the city. And then another program that we offer that we can do an overview on is this special diabetes program for Indians. And we offer programs through health promotion. We have a fitness center here on campus that services the community of the city for the most part. But in addition to that, we also offer services, our grant funded services primarily for youth. Children that have problems with obesity, and we partner with our pediatricians here at the hospital through referral service. And so they offer demonstration, meal cooking with their whole family. It's not just a child, but the whole family. And then we offer the fitness center activities there for the whole family as well. But that fitness center is open from 5 a.m. and there's a consult 9 o'clock at night for the community members. We also offer a senior hour from 9 to 10, where elders can come in and utilize the fitness center with the help of these specialists that we have on staff. Then in addition to that, we offer all the community-based activities, including activities like JMI, hiking series, and just a variety of community-based activities in all areas of our service.
You answer the next question. About acupuncture and naturopathic medicines.
Sure. Dr. Brooklyn, Chief Medical Officer. Before that, I just wanted to add to the behavioral health. One of the things that we were working on as part of our strategic plan is to actually bring in telemedicine for acute care psychiatry for overnight. This is something that I've worked and other organizations I've worked with. It's because we have a limited number of mental health professionals can't cover 24/7 call telemedicine with the psychiatric service using the screens and that emergency part of it is one of our goals. So hopefully further enhance the care we provide. As far as alternative care, so we have had physicians that have provided acupuncture. Actually, one of our physicians just left, but another physician is currently receiving training in acupuncture, so we'll continue to provide this service. In addition, we're looking at doing a kind of a multidisciplinary pain management program. We have a lot of interest from different departments, from orthopedics who are talking about physical medicine and rehabilitation, from our anesthesia CRNAs who are looking at doing some injection programs, as well as acupuncture and osteopathic manipulation treatments by some of our DO physicians in family medicine. In addition, we have from our colleagues in physical therapy, we have some that are working on dry needling as well. So we do have multiple approaches to pain. I think our goal over the next year is to actually try to coordinate and build kind of a path so that individuals who need these are directed to the right treatment, the right place, the right time.
Then there was a question about the tax or a conversation about the tax market credits. I'm just not all that familiar with it. I know they exist and it's not one that we haven't even looked at yet. But it would be certainly something we can look at to see if that will work for us. I know they all have their inherent risks. And various things we would have to consider. For those, we did look at USDA and partnering with them for our long-term care. They asked, so that conversation, we finished with. Then they want us to look at other opportunities since our, cash was, I guess for lack of a better word, they thought we were in good financial standing and they asked us to look at other opportunities banks before they would, consider or support the USDA loan. So for lack of a better way of saying that, that was kind of what happened with our USDA avenue of a tax market credit, something we can certainly consider and look at going into the future. Okay, one more thing we'd like to also bring up too, we do have a Navajo Health Foundation, which we didn't include in the slides that, in my oversight. And they've been very active as a board themselves in their activities and supporting ways to fund, ways to support the organization. Can I give some time to Mr. Thomas McCabe to speak on that? Our president of the Navajo Health.
Thomas McCabe, board member, also current president of the Navajo Public Health Foundation. We've been working with a partner to develop a film on cancer patients. Cancer treatment on that organization. And so this year, we've been going out and screening these different area in the states. Started with Philadelphia, and then here in Flagstaff, and then to Washington DC, and the next one's going to be in San Francisco. But with this, we have corporate sponsors also that help us in getting the support and also finding additional support for financing for our foundation. So it's been very active this year. And primarily getting the word out that our cancer treatment is very important, very needed here. And because of the issue with uranium and the lack of government finding ways to secure those uranium safety and to also lack of work to people who live in those areas and getting exposure from it. So that's the message that we carry out to the people out there with our support of our sponsors. And so we continue to get more benefits from that. And additionally to that, we also have funding for scholarships for our mentor treatment, helping the patients with their needs. And then we also support the hospital with any additional needs that they have. And sometimes these are needs are pretty immediate. Like recently, we got a request to buy a stretcher that's narrow and shorter so they can go through any of these doors. And so we went ahead and purchased that. So things like that, we help the corporation with that. Thank you.
I think that's all the questions.
Yes. Couple minutes, it's not bad. Just to go back and since now, I did get on the board. Thank you for a good reminder on that. A board needs to stay within your limits. I know. Let me just see, I just want to kind of go back on that, and I think, I believe that our board is very, I will call, we call ourselves a professional board. And we know our clearly standing as a president. We've asked our board members to go through the president. Upon that, the CEO, the CEO, any information that's shared with the CEO, the president, and the executive committee. Staff needs to be, there's a lot of issues. I don't feel to find the need to address to the board, will come bring it before the board. To say mission for. I don't, often the bylaw of the car. I don't see. I don't get the husband, so the neighbor is probably you'll be charging check, so you'll be because you never about me, the other way, I just cannot be no passing state. I don't on the chat with them, I go to office, check the housing, go pay the housing. I need to go, this board member class, I don't report president. I see the house, it should just see over the time. What are they just spread to see even it's a native or it's a native board members, it's deep passion journals are not able to card, probably they start with nigger with them that is see over to they could I give that the stage in city.
I think I missed a couple of questions and then go back. There was a question about dental care. I think we talked a little bit about vacancy. Just with a general overview about dental care, it is a challenge. Our dental assistants and probably one of our is our limiting factor on our being able to open more dental chairs. With that said, it's still challenging to get patients in. We still, unfortunately, when patients do have to come in and try to get them same day appointments is always challenging. We did open dental services at Sacred Peaks, which we didn't have before until last year. We also added 2 pediatric dental chairs also at our Cameron Health Clinic as well. So we're finding access, it's just finding dental assistants so we can make more appointments available.
Yeah, I know, again, Dr. So thanks. No, so as our CEO mentioned, the dental assistant shortage, and specifically with pediatrics, pediatric dentist vacancy that we've been unable to fill. I think we do a good job of taking care of emergency dental care. For the other part that contributes to this that we didn't really talk about was that during the pandemic, we were essentially closed for any routine care. It was all emergency dental care. And so coming out of the pandemic, then trying to get caught up with that backlog of overdue preventive care is continues to be found. But I think again, as was mentioned, we do have increased capacity at Sacred Peaks and now Cameron, and we have more chairs even as part of the COVID funding that Mr. Young addressed this. We did some renovation for airflow and other things to open up more dental chairs. We're just going to use them until we get the staffing.
Now, the final question I think around housing and efficiency.
On the housing, when we do any type of design, we do look at the program in terms of it, which basically sustainable energy efficiency. A lot of it is, the older buildings basically didn't have those designs. So anything that we look at all that in terms of we're trying to, I guess, save energy one is to be efficient in terms of it. So when we build these houses, we'll do the things that we look at. Although it may be a little expensive, but in the long run, basically looking at retention and cost to the tenants that are there. So we look at all those areas. In fact, the units that we're talking about, we do have that sustainable energy process. So anything to look at that. A good example is what we're doing with Broadway Gap, the clinic there, healthcare there. We actually are following the LEED program, which is the gold standard that we're looking at. We're also going to be looking at when we do the housing, but right now our biggest one is the healthcare of it. So as we're going through the designs, we're planning to complete by the end of October. We want to basically have that LEED program And then we'll start constructing the bid boards, what we're looking on that. So everything that we do, we look at all those tangibles in terms of it, because, you know, at the end, we don't want to have a high cost on the other end. Well, that won't be here 30, 40 years from now. At least we get to see the rebate and all the costs and things like that. So, and the savings on that.
I think that the all of us in my department, I don't think that's.
Dr. Chief, I could have Walters before I recess for lunch. I do want to make 2 points. First, the first year, Honorable Vice Chair did request some of those challenges. Maybe yourself and the board can convene with your board of directors to provide at least a 1 to 2 pager to the Health Education and Human Services Committee. I know many of us go on our respective student schedules, and oftentimes we come across people who we may meet at the right time. And this is one of those areas that I think this document can be of help. I also know that some of our colleagues take trips to DC. And for me, what I'm going to travel across the country, I'm going to make the most of that time. And this comes with meeting with additional folks. And also Vice Chair serves as our IHS rep for HES. So she also has direct contact with Ms. So and her team. The second thing is from the president, Mr. Curley. He did mention the 638 orientation or meeting on the 28th and 29th. They just needed I did a quick search on my email. I was unable to pull it up. I also checked with our legislative advisor, who is, by the way, the point of contact for Health Education and Human Service Committee, who is also does not have received that invitation. We'll get this. Okay, so that was the second request, was to just share that. Colleagues, I am going to break or not break, recess for lunch. We do have student fried bread. She could not be able to give us that for that community that we think. Yeah, thank you for providing food. Colleagues, I'm going to do a 15-20 minute, let's go 20-minute reset for lunch. If there are no objections, hearing none, we will reconvene at 1:10 on the dot. So colleagues, I'm not sure if you're leaving lunch. I know it's in the lobby, but.
You guys.
Can you a motion? Is there, did you ask for a motion?
Do we have? Sure. I just need that.
You can just do a recess, yeah.
Yeah, that's what.
Thank you.
Here in beautiful Chiba City. We're here at the Regional Healthcare Center conference room. We do have current forum here. We did vote into recess, so we don't necessarily need a motion to come out of recess. I determined that on behalf of our meeting this morning into this afternoon. But out of courtesy, I will ask staff to assist us. Ms. Thompson with roll call.
Good afternoon, Chair. Roll call coming back out of recess for August 21st, 2023 at Chiba City Health Regional Healthcare Facility. Honorable Vince James is excused. Honorable Jermaine Simonson. Present. Honorable Helena Nesbigay. Present. Honorable Dr. Andy Nance. Honorable George H. Toe. Honorable Curtis Anito.
Here.
Pro Tem Chair, you have 5 members present, including yourself, which constitutes a quorum.
Dr. Chief, we have, Ms. Thompson, so we are back on to the presentation. We're hearing the annual report of the Chiba City Regional Healthcare Center Corporation. Thank you for that, it was great. But moving forward, we will continue, to discuss the report that was provided here to our community members. For the budget, moving forward in that same fashion. So colleagues, I'm going to call in, if there are any additional questions or comments to our team members from Teresa. Colleagues, any questions?
Thank you.
Takoshi, we're moving forward, honorable Shimele, honorable Miguelito.
We're not able. The next one. My question would be, how often your department work with, like other 638 programs,
Yeah.
you know, across the state, or I think this was across any state. And as far as your 501c3, and you know, you have 3 tribal members that you guys operating with here. And the support of Arizona, state of Arizona. Because I'm always thinking about 638 program in Utah. I'm from Utah. And I deal with Utah Navajo Health System. And they really work closely with the tribe and the local communities across the 7 chapters, the Utah Strip. And so it seems like, you know, they really are expanding, you know, like in a lot of different programs and so forth. And, you know, they really work closely with the, Navajo Nation. As far as funding, they work with the Utah Navajo Trust Fund. They do matching funds and so forth. And then here, you know, they really support the traditional practices. They have a whole down like guys like both last forth, and they work with the local practitioners. And it's really handy. There's a lot of times the doctors they can't really, you know, see the symptoms. So that's where the practitioners come in and it's evaluate and correct. You know, there's health issues. And you know, you guys said that you guys are having a hard time recruiting and hiring the Utah Mental Health System. They have a program, like a nursing program with the colleges, local colleges, state university and so on. I'm just wondering if you guys are working with colleges as well. Because the program avenue, they start from high school into, they have a program, nursing program, and there's another program that's been introduced, but I don't think that's different. The health system. The other one is more about construction and so forth. I just had those two questions, I guess, as far as 638, that you guys have a close relation to this plate. And I don't know how you guys operate, but it sounds like you guys are really productive as far as 638 program, and I really appreciate what you guys are doing as novel and operating like that. But if comparing with the Ethanol health system, they really work with the state of Utah, and then a lot of the facilities that they have more geared towards the public sector, and that's sometime it's not a lot of the employment and everything comes from the non doctors and nurses and so forth. Yeah, I just had a question on that, how you guys are operating on that. Yeah.
I just want to come to the vote. Committee members, any additional questions? Honorable Melina Gates.
Oh, that's my honor, good afternoon, and thank you for lunch. And, I have several comments and I have several questions. We cover most of cover all my 5 delegate regions. For the recap, top of mind, which I equal and unbelievable. And I know in high level the chief services between the regional and the service area, which is going to keep us. A lot of my relatives that live in those areas, they need a lot in I'll say medical center, so that's the way I see it. And I really appreciate giving us some time to share the services that we provide for our people, my delegating and surrounding areas. We have package increased living independent living in Idaho. And I was part of the planning when we were designing that. And so we were beginning of that. I was bringing my elders in and expanding in those planning for aging. We still have the in there. And what's the name on the roof? Walter Bell was on the committee with us, and we really came up with good design, and it's we didn't go with that design. But more kind of how we want it and how we want to be supplied with it. But today we have like two facilities say two units are always. And we're utilizing three units there. And it's not just for Idaho, we have other elements that are coming off. Like from Home Line or from Cameron, from Chantal. And they're utilizing that facility. And I walking off the field as being a senior center supervisor into this role up here now. So working with the elders there at independent living, some of them always complain that it's really hard. most of them, they're fixing kind of goes into the. And then you can, she can convention, so. So we have to look for food outskirts for them. To carry them out for the food. For the month. Another thing is that. We service the area, we carry all the clients there. At independent living down at the senior center. And we only have one van. That transport up there to the senior living there. We have all the meals, hot meals there. And the van comes back down, loads up more food and some hours out at the center. On that, can go out to the public. So in the future, maybe we can plan to get a driver, a vehicle to transport and regularly provide service. It's mainly for the Huntington Creek, the living facility there. And so that's what I want to see. And then that's more employment opportunities in the community. I people. And I would like to see a television doctor's appointment for them. There at the facility where they can come in and they can talk with their doctors there on the screen and that way they're more comfortable doing that because some of them. I know that, we had a grandma that was like 98 years old that was living there. And the last month of her life, she wanted to come home. And it was in that village. She goes, she came to Hong for you. I don't see, I don't get in the room there. She came up, not with this. And she lived there for about 4 years. And she gets so happy. And she lasted like for about 4 years. And then she and they really like that facility. The way they wash it and dry it and and we still provided, we came up to the facility. And we provided activities there for the patients that are working there in the buildings there. Because a lot of those clients that live there, they didn't have transportation. So if we can, this was the plan from the beginning is that we wanted to put our senior center in the middle of that whole facility and provide a senior center in the middle of it. So the reason why we wanted to do that is so the elders, the clients, could just walk over for meals, for activities. Because some of these elderly, they stay in the rooms, in the little apartments all alone. Sorry, Ashton, but then they have like two with their provider that comes in. And so, they want to get out. So, when we were designing this, that was what our whole purpose of planning was, right? So we wanted a senior center in the middle of it, so we can have our elders come walk in, sit in there, lounge around, and do the activities, because we did have activities. So sometimes our van had to go up there and pick up those elders that wanted to do activities and bring them down. Or you have the one van, a lot of elderly over there that want to come down, they fill up the whole, our little suburban. So if you not, maybe if we can get a suburban or something for that facility for that our senior center is down below at the chapel. So So those are some of the things that I experienced as a supervisor there. So I wanted to read it out to the people, and I'm saying this, and I'm advocating on behalf of my elders. And as an elder, I need to get lonely. They want to talk with someone, and some of them, they still do little things with their hands, so, you know, that's the reason why even sitting down doing puzzles with them and socializing with them. You know, that's what they want. So they've been, you know, that's the reason why I was saying this, and that's the reason, that was the whole reason why we wanted to see us. And you know, left. And then we about that in this kind of living. Although, and but some of them, they go to the doctors and to the city. Although, if they come in with a safe ride, sometimes they can wait another hour to an hour and a half for the pharmacy. So they call down to the senior center and ask if their driver can go back to Cuba to pick up their medication. A lot of time this happens. So we did send out my driver to get the medication and bring it back for the elders that are doing at Silver Medical Creek. So those are some of the things that I encountered there as a supervisor. And then for the community upper mind and for TV, you know. I've seen the education partnerships in here. We have students from Upper Mine, from Bottom Gap, the Bigger Springs, and from Cheaton. And they go to school at Page High School. Although they go to Hokkaido Community College. So maybe you guys can reach out to that community college and play, because I know the students that are interested in becoming to start their career in nursing. So they look at that they get to teach. So even down to the students, I know there was a young lady from Page Hospital that used to come over to the high school and use some of those students that my nephew started his career with nursing from high school there. In the Page High School. And they started, you know, working with that patient there and, you know, little things that they do. Some of us got interested in all that. Page High School has like maybe 90% of Native American families move there, right? I know, that's why I used to work at a school there. So even maybe some working with this really good too. Not just here, we just let's go out. Because we're every time we want to have service in Keontaek, they always chase us back. You guys are in the city, we're going to the city. So that's how we're treated. And even with services and inscription house, we're told that we're in the city service area for the city. So that's the reason why I'm really advocating for the most happen. So we have students, we have children that are going out to school to Phoenix, getting their education, with their field coding and field medical building programs, and some of them are stuck in Phoenix. So somehow we need to bring them out here saying, and I really did advocate for you guys when I went to Mesa Community College one day. They invited me over and I told them to go back to the reservation. We need you to get you guys' help out there. So although that one student goes, they gossip too much. at Tuba City Regional, they lost too much employees. That's the reason why I left that program and I came down here. So. And this is just what I'm hearing of the student there, so maybe, you know, actually, me for fact that's a possibility, everywhere you go, it's like that, that's what I said to, it's just you yourself, you gotta build yourself up something. People that, are reservation, they how can you get to where you are, need to do that. Although, and and then also I went to the University of Crown Point, Technical University. I went to their graduation in May and on me or you, they were doing their nursing going there was like maybe 3 or 4, you know. Now they're, you know, they would go off to work at the non-general. So, you know, maybe work with that program too. And a lot of our kids from here, I had like probably about 5 or 6 from Western agency that graduated up there in May. So, you know, but maybe somehow, you know, probably visit that school and talk with them or something. So, you know, a lot of it, I had 2 inscription girls that graduated over there and one time. I think it was by the way, somebody by the way in my too, so. I know, mobile, medical and dental, every time I drive through my delegate region, sometimes some mobile, I'll suffer something with it, so we so, you know, maybe give me an update, what your challenges are. Do they really utilize those mobile units out there? And dental services, other than your dental services, like I said, I was looking at your chart. And like I said, Page High School, Page Unified School, a lot of our neighborhoods are going to school there. Why can't we provide dental services for them too? That's what my next question would be, because a lot of these children are low income, they're coming from home that has low income. I call AU, they go, they are the not sure that they see this year. And other than that, I see everybody's on the list there. So I go on the healthcare, but no, hold on, some next, those the one that hold on. For medicine man to come in. There's a hospital, the regional hospital here. Do they help the patient pay for medicine? They go. That's one of my questions. They go. I don't know. I go, I heard someone saying that, the patient, I mean, the one that needs to go online to do the, survey or something like that, I think that not everyone on the rural reservation like in Kakamon. They don't have access to internet. They don't have computers or anything like that. They are the chicane that the I gave or or OEA from here is not pushing to bring running water to the people of Copper Mine. So we really need to do that. Or I'm giving you a our students that goes to school that catch a bus 6 o'clock, 5:30 in the morning do not have running water. And this is in your region. So there are data on your medical records, there are data from Tuba City Regional. Let's bring water to Kakamon Chapel. first windmill, they drilled a well right there. Again, the next, they don't have running water. So we need OEH trucks and not. I did my research on that, when it comes back to OEH. Where I live, 7 miles from my house, I still haul water, I do not have running water. And I've been, like I said, I was born here. 60 years out there. I still don't have running water. Appreciate face on the jet. My mom never had running water for her. This is what they advocated for. Some of them left without seeing running water in their homes. So OEH really needs to work with the communities. When I come out to my entrance on my home, there's like about 15 students that get on the bus. And these 15 students still have no running water. And OEH needs to get on the ball and start getting water to eat. Yes, let's not just be addicted to them. For so long, we advocated for running water. Who's gonna bring it to us? Oh, so the entrepreneur, we want running water. But our young people, I know what they struggle through. Especially in the winter and a storm to where they still have to go outside and do the outside. Indoor plumbing is what we not. So when you bring your OEH now, then this is what I said from my council meeting on that. And then I'm really thankful for you guys to open this brand new facility for my Lodge Lionel announced it at our chapter in Kochi about the long-term care facility. I really should got there. But thank you, city. You don't know how much I appreciated that. Because looking at my elders, going to Winslow, going to Landings, visiting my elders in those healthcare facilities. When I was a senior center supervisor, we used to make little aprons, a little blankets, which is not the children. We can't touch each other. I look at what they are, the care of the vaccine. She died, the yard goes on to. For healthcare, you need to the heart of baby, they need to check the net on the building. They might have an appointment here, and if they know someone over there, they just walk across over there and visit with them. You don't know how much you're gonna expand somebody's life. That's the bottom line that you're doing that. Harder. The kid that you're soft within that you're soft. This God, you're what's taking you not going to talk about that within that. So that's so be ahead for me this long-term care. So of course, I got a young she did Jules, highway between Highville and First Mill. And like I said, Highville Creek is right there, and the highway I'm requesting to Taylor Road, a highway between Highville and First Mill, so you have access to emergency. For example, I'm going to put out and we're working on resolution to pay that road to request for a payment. hydrotol and cleanup. And I was working with Lisa on this, so we are still working on that, so. It really, been yet, so, I guess, so. Another thing that I encountered there is that, when you fly out someone from here for treatment at other facilities, off the reservation. You guys make follow up on those individuals. That make sure that they come home safely. Don't just fly them out and forget about them. Make sure they have a way home. If they deceased out there, make sure that you know to contact that family. The reason why I say this is that I had a social service that was calling on me. Do you know this individual? I said, yes. All I got out of her paper was it said hydrotol. And we've been trying to follow around. This is our third day, so we figured we'll call the senior center starting. This individual was flown in and she deceased, and we cannot contact any family member. I says, yes, I know who she is. She used to volunteer for me here at this senior center. And I went out to contact her daughter, and no one went out. But during COVID, they couldn't let them, she didn't know about it, that her mom was going out. And we can see out there, and if we don't get contact in 24 hours, we're just gonna cremate her and just lay her to rest with unidentified individual. And I sat there and I thought, how many of our Navajos were treated that way? So, you know, this is just something that I've experienced, and that's what I'm sharing with you. So, somehow, you know, you guys need to follow up on these people that you guys find out. I go on the and my other half, my husband. We've been going to Flagstaff for his medical everything. And he was coming back up because of the distance of travel and because of the cost of gasoline. We figured, don't come back to the cities that were in the region area. So we did, and not ever since then, we started coming here with him. It's just the time. He's not getting any better. As for he was, he's just going down. And doctor that is not making the oil of them, he's fine. I lay back. Then let me finish the not going to finish. So how appreciate what they got in there, put the foot on, but we do a lot of Indian Health Services. Many dollar, I got saying, I young, she. The share with insurance for basically the need to go. That's where I'm at right now, because I'm the one that feels with it. They were on my shovel, I get called to check on him. I go physical therapy. I'm glad that you guys are bringing physical therapy to the tree. Thank you, Lionel. You probably advocated for us. Yeah. And talk them on. And I'm glad we have board members like this on board that can advocate for us. For bringing that to people cheating too. Because they did the gym. Son, you a studio, the chin, the cave, questions about when you need that. We can come here also to get the physical therapy done and all that, and then the chief pharmacy. is really a great plus for us that we hope continues to grow. And other than clinic there, I don't know if you guys want to shut it down because of body gap. You know, it don't successful. If you're gonna shut it down, maybe that's the reason why this so many people still need here, I don't know. So enough of that. I will thank you on behalf of the veterans that you bring that clinic to here. And I know they travel a distance from here to down to Phoenix, so it's not for their services and honestly, we need, and I know our delegate, honorable delegate, Damien said Damien is working on that. Drug legislation for the veterans hospital to be built on the reservation. What's our age? Should negotiate for you know, put on the hospital, machines, so when you in general, and wanted to come to the understanding of what our kids are really going to do out there. So, and I want the board to know, I want our CEO to know, and I think to bring these services to our people here that we're still lacking, and the service that we are going to have, they have, thank you for that, and the services that are coming through that you're planning on, if they have. That's all I wanted to talk about. The hotel.
There are questions. And a lot of the representation to what our families go through. I'm a believer that when we're out in the communities, we truly see firsthand what our community members are going for. We have some advocacy. I do want to address some of my questions as part of the HES committee, and then I'll give an opportunity to Chanel and Mr. So. Should also address the questions, and then thereafter I'll go back to Ms. Walters. So the first question I have is the primary reasons our relatives visiting to the city regional. I know in your slide you do have an area of emergency, but it would be great to see sort of like the top 3 or the top 5 reasons that our community members and our Western relatives are coming to our facility here. The next thing, and I'm glad Coach asked about it, was the fentanyl. I did a fentanyl training at South Zone Medical Center, but it also brought me into like a response, community response, and I know sometimes that's often lacking in certain communities, especially with like Hurricane Hillary. I don't know how much of an impact we're going to feel on the side, even though it's just rainstorms. It could be just rainstorms, but to us, it's not just rainstorms. But it has a very significant effect on our people. Just as far as preparation for large scale matters like that within the Western area here. The next question I have is on child care services. I know part of the reason that a lot of personnel, even within hospitals, outside hospitals, with any employment, they tend to have trouble with finding care for their children. And I don't know if the city provides that. If not, perhaps that's something. An opportunity to retain employees if that's the case. And then the mobile health care, the visiting, that's great. That was one of my questions, but as the presentation comments, I've seen that you do have it. How frequently do they visit schools? Because I know here in the Western region, you have, Shanto, Great Hills, and district. And then that kind of goes hand in hand with the education regarding STDs and things like that. And then just kind of walk me through what that looks like for the mobile health care. The other thing, when it comes to health data, one of the things, my biggest criticism of health facility, any health facility, is that they don't capture data on our LGBTQ+ relatives. It's always male or female, and every time you go somewhere, it's either identified as male or female. But I firmly believe that that's false dichotomy. I don't believe there's a binary there. And if we're going to truly serve and cater to all of our dinner relatives, I think it's important for many health institutions to track that data as well, so that we're better supporting our communities as well in that way. The next question I have is like town halls, because Tuba City Regional host town hall. I know you talked about the survey that was conducted back in 2021. Which, by the way, I don't know if that report is posted on your website or you can see a copy of that. I'm a data person. I love numbers. I love facts. I love realistic things. And a lot of the meetings, I didn't ask for those questions or those documents. And then the last thing I wanted to address, aside from what a lot of my colleagues have also posed, is sort of the process from triage. If I come in here, or if I bring a relative in here, what is the process from triage to getting service to be flown out, if that's the case, to Flagstaff, to Phoenix? And then where does Tuba City stop corresponding with its patients? Because initially we checked in here with the benefit of obtaining service from Tuba City. But if I'm stationed in like, I don't know, Tucson or Phoenix, in a bed somewhere for like multiple days, 30 days, 60 days, then does Tuba City kind of correspond to say, hey, as our residents, as our citizens, this are what we can still do, or is it solely based on whatever new facility that the patient is currently in? And then coming back here to our doorstep. Because one of the things, as you maybe know, is the Operation Rainbow Bridge, which is in Phoenix right now. And that's one of the questions I posed to the group when they were developing their task force. He walked me through everything, walk me through the time where relatives are discharged and then what happens thereafter to bring them back safely. They don't want to come back on to Navajo, then explain what that looks like. Because you can't just say, this is what we can, and then thereafter it's like, you know, it's kind of not our responsibility, which to a certain degree doesn't make sense. So I just wanted to ask this question. Thank you. So now I'm going to.
Thank you. The chair, first of all, I use it to move down. Really strategizing and thinking outside the box. A lot of these services worldwide. Oncology center. You didn't have to build it. The senior living center, you didn't have to run it. You didn't have to apply for it. But thinking outside the box, you took that step and say, hey, let's build a facility. Let's expand, let's get a mobile health, mobile running around there. We can this service even. You know, this is see it park at Gap, or park at Tree, or park down at the village when you're going out, or seeing a park at you at Cameron. Really gets you quite a lot big. I work with Indian Health Service there. And you're the 121 of the room. And at the time when the board decided to go Title I. And to actually say, hey, we can do a better service than the federal government is doing. So at the time, the leadership, the navigation level, that the council, that was their goal. And then with the board. At the time, it was the health committee. And then it transformed to the Tuba City Regional Healthcare Division. Oh, you doctors will stack on to that. And then the reversion. You're bringing over the Indian Health Service employees over to the Tuba City Healthcare Division. And that went through that transition. Through along that process, you had a lot of wrong about you. CEOs at that group, and trying to get this hospital in your what you follow, your rules, your plan is basically off of what is federal law. You operate off of what the federal government has in the form of CFR. You shall operate a federal hospital utilizing this standard. And that standard is. You could get to the regular Indian Health Service standard. But you're above it. The General Indian Health Service. If you look at the services, that. My wife, she's a respiratory therapist. And just looking at what equipment that Indian Health Service utilizes, and what this healthcare corporation utilizes. It's not even dated. They have this thing that are outdated. An example, Chun-Li. This thing is like the dinosaur. And they're trying to utilize to keep the patient alive. And they watch, and they. And odd, you are continuing to grow. And I really like the fact that we reach out to Winslow Healthcare Corporation. Also, ourselves. Final position right there. His area. Montezuma. And we keep that collaboration over here and try to learn from each other. The time when yes. One little down on the whole too, decided to say, hey, let's sleep outside the box. If we can keep the creator. These healthcare corporations that we ever wanted to have fun. God, she's up in. But it's just like to say that, you took that initiative. And Title I is formed of what? 1975. Richard Nixon signed that into law. Gave Indian tribes that opportunity for us to run these facilities under native control. On the CFR, State Washington, State County, Washington. For the here in Tuba City, that CEO, the driver's seat of this bus here. A lot of expectation is on the former CEO of the Nanaza. We get into some sort of leadership. Change it up, the auto so take a number. Well, there's an issue too. But I really appreciate that where you are taking this preparation and reaching it. Because it's really big. And at the same time, maybe we try to Montezuma Creek, tell us something. And look at Windsor. Tuba City Healthcare Corporation is unique that we have two other neighboring tribes that is partnered on this. Their data, their information is counted inside funding agreement. Look overall, they can offset the costs. We know that the funding agreement that comes down from Indian Health Service each year. Congress has got the budget. We don't know what type of effects it happens in the FY 24 and 25 proposed Indian healthcare corporation or Indian health budget with the debt ceiling negotiation. That negotiation determines based off of what happens in winter. Or not winter, actually Washington. If Washington, we continue to have the same Senate, we will always get less money. And that's where you're going to make that decision when the funds come to what services are being provided. Service in this area needs more, this area needs a little bit more. We got a little bit more money last year, we had to take some away from it to move money over there, so you're basically robbing Peter to pay Paul. To try to get out of service. But, there's on before, and I think, looking at this, I think that, you're in a really good position. That we do allocate for something Washington. And maybe in the future, but the partnership, we really need to bond. It seems from the last administration, the partnership wasn't there. The nation wasn't there. Only your Title V on the cable jack. That's basically what has to be told. Alcohol, but looking at the bigger. The nation has given the QPHE to the health corporation. To receive the funds. The nation. For that data. How can we try to go back to renegotiate such as what you alluded to earlier with the CMS issue. With the $625 rate reimbursement. And then it's with how the cost that different. What is that number? And it's good that there is a consultation for them. And I think that through the consultation and through the hearing or consultation that's been happening, I advise that the board does a resolution within the board, and that we do entertain a committee resolution. It's important. Because with that government election. Indian Health Service should be able to bring that information, so our trustee. Now our trustees communicate with you, but they have an obligation to communicate indirectly with the nation. Because that's who the treaty is with, between our own nation and the federal government. Things dealing with government positions really need to bring it to council for the PFP. Now, the PFP committee is a unique committee, standing committee that can directly impact the Congress, because now it's basically the former government service committee. They dealt with the national issue. APA in a standing committee in support of the policy change to allow special circumstances, oncology, and other such services to be reimbursed at that rate. Whether it's an elder who is getting funded based off of Medicaid or Medicare. They never retire anything with A, B, and C. A is pretty much, I think, it's like the bare minimum bonus. Then the next rate is like another higher rate, and the C rate is the higher rate. They take the monies from the individual who received the retirement pay, because I'm based on the insurance. By SB, a lot of our elders out there are living on these incomes. Social Security. Now, depending on how, whether they're with your spouse or how the individual work, age with Social Security. So a lot of them think that need to face anything. They don't really think about incorporating the health aspects into their families. And somewhere I'm not too sure whose responsibility that would be. But we have to educate ourselves. Even though he led not be that way some happens and here you are covered. But again, if that public education somewhere has to happen, and know that's an individual responsibility. Sleep option. I saw his social security benefit dropped from $670 something down to about $490. That was a difference. If he factored in his own costs so that the family would not hold the burden on the individual. Hi, we come. Hi, she come. Can should have flash on them. I don't want to. Oh, I never really think about it. You know, each family is different. And if they those are some other things that I think that's another thing that they need to get so really administration to really educate our elders. It's impacting families out there. I don't that there's a treaty obligation. Actually, not being the funding agreement here. In all the 630 contracts, it's based off of funding, the availability of funding. There's no room for negotiation for increase. It's the same for public safety. And even now, somewhere we have to come back to the table to get that rate increase. In servicing. If it's a government facility such as like Chinle or Northern Washington, that's in their control. They're really 100%. Let's application site box to try to go. You gotta make that argument to the federal government. Yeah, you can apply your rates over there, which the facilities are under your control. But over here, we are at Title 5, Title 1, and we can proceed to go to negotiation. We want a fair share, basically, what we should complete. Of all of the things. Washington, North Carolina, only this year. Whether it's the Bureau of Indian Education or the Bureau of Indian. We have a treaty obligation. That treaty obligation is not saying, give me more and more and more. Give me the fair number to us. Whether it's whether it's a family of Southern Taiwan, whether it's now 80 in the you look at the federal budget. The federal budget, the Indian Health Service, about 51 billion.
Chanel, Mr. Seth, I'm gonna interject real quickly. Do you have any particular questions or comments relating to the presentation from the city region? I know there's a lot of background and information that simply supports the report, but just to the agenda item.
Chair. I know the SN, there's always territorial deal. And no wonder about way over there, and they're way over here. But I think that it's about a question. It's the facility that the community that is providing service. If I were the number of minorities parent, I would be saying that would be saying the same thing. But since the healthcare corporation is here. If the thought is to muzzle them at the committee level, I will yield for. And with that, I'm sorry for holding you up, the committee. But again, UBC Healthcare Corporation is one of the largest service areas that helps. Even the national budget impacts it. Areas that I talked about impacts it indirectly, the construction, there's other things we just won't be. The long-term facility here to the state. The domestic violence shelter. Oh, I knew it. With that, I want to go just end my comment here. I don't have any questions or anything. Thank you.
I appreciate it, Janelle. Thank you. Going back to GC.
Thank you, for the questions and for giving us some time to clarify. He's talking on the list of I've written them down. Today about the 638 programs and how we work with the 638 programs. The association, the 638 association is where our the board and the CEOs meet and convene and share best practices, share updates in different organizations. Like Utah, we also work with the state Medicaid program. Our CFO and her team works a lot with them. Our CNO, our nursing chief nurse officer also meets with Arizona Hospital Self-Healthcare Association nurses. So we do have we do meet with them as well and have updates and share that best practices. So we are doing those things, and the ordinary Medicaid has been very good to us, even with specialty meds. They have a process and they do reimburse us. And that's one of our comments that we're making to CMS is Medicaid. I thought they're already doing it, so how come the federal government can't do the same thing? And that's for oncology and reimbursement. So that's kind of where we're at with CMS, and we're still drafting those comments. And we have until September 11th to finish that up. So I think we do have a really good working relationship with 638. Another example is domestic violence shelter. When that proposition came to us from the social services, Utah already has them. So we met with Utah board members, we met with Utah's leadership administration, and they're giving us a lot of support and guidance. And I think we're both ways on their what they're building over there. Bilcon facility, we have meetings too, what are some of the things they've done, what are some of the things that we need to watch out for as we move forward and go on with that. So I think that collaboration does exist. There was a comment about local colleges. We do work with the local colleges. NAU, so NAU had a nursing program at Fort Defiance Hospital before the pandemic. And when the pandemic came, they closed it because a lot of the schools, they didn't have their students in these facilities, and a lot of facilities have kind of slowed down services. So NAU quickly turned to us and said, can we bring that program here? We already have a working relationship with NAU. They would bring their students, same with Coconino Community College. Their nursing students did clinicals here before COVID. The new thing though with NAU is they have a campus. We're like one of their satellite campus in a way. They have a simulation lab. I think we might be, I think we're the only one in this area with a sim lab. So we have mannequins that kind of help facilitate our learners, so they can learn different things using simulation with mannequins and various things. And so NAU brought their classroom here. Their first Native American nursing cohort program started this past fall. This is 22. So they did. They've been on site. They've been on campus. So they'll probably bring another cohort program here this fall. I'm not sure when they start, but we have that program. So yeah, it's a good pipeline. It's a really good pipeline for bringing nurses. I'm one of those nurses that started with NAU, did my clinical sites there, and then I came
right afterwards. I know a number of our nursing students and a number of our graduate students do similar things. And we always look at pursue that. That's why we really, I want to say, we really pushed at A College to do more healthcare. And that's why we're looking at most important. Really getting these schools to come talk to us too. Lene College is barely starting their healthcare and allied health services. And so we started that program with them. One of our nurses who's moved on, she got her next degree, she's working elsewhere, but she helped facilitate that whole conversation. I remember going with her to Lene College's board to talk about bringing that here. It's like, I don't know if they have that only. I think it's been at least 2 years, maybe 3 with that. We're going to start Lene College what was the program we called?
The medical technologist practicum.
Yeah, so again, we're gonna be with this first thing with the medical assistants. Lene College, I think, has saw the success with that, so now they're offering medical assistants, so now we'll have more lab personnel doing clinical practicums here. So I think we've really been working hard and we continue to build relationships. Kaiwato Creek, I think a lot of what you shared, I really appreciate that. I was not in this role or really was part of those discussions when they first started, but they seem like really legitimate concerns, getting care to elders and being able to provide that. I think I have to talk to my senior leadership team about how can we mention telemedicine. I think that goes to our mission of giving access to care. So that's probably something we can talk about how we can even maybe the mobile units and talk about how we can improve care and services there. Moving on. Training for students. During COVID, when patients were getting transferred out, we did recognize that as a concern. You mentioned how patients were sent out and then kind of lost contact and people didn't have, there was a lot of things that got disconnected with COVID. So we started our case management program, case management programs really reorganized themselves in the last couple of years. And then with that issue that was happening, it wasn't the only one, people were trying to find their loved ones. People were sent as far as Vegas and we were trying to bring them back. So our case management does follow them. And I think we learned a lot of that during COVID. We've also are implementing and have really working to get a probably more robust program around discharge planning. That's one of the patient experience customer service programs with hospital. We call it I call it HCAP. I can't think off the top of my head what the acronym stands for, but it's one of those things that is important in the HCAP patient experience. So discharge planning and really keeping that connection with patients. How do we do that? And I know our case managers are working and organizing themselves better around that. And so we're working with the nursing staff too. HCAPS is just for inpatient right now, but come January, we're working on getting it ready for ambulatory surgical services. It's a new requirement. It was only on inpatient, CMS only required on inpatient. They're expanding that into the outpatient ambulatory surgery. So we'll be expanding that. We're expanding that survey out to that patient. I think the concern you have, it's hard to listen to that, but I know that those are legitimate concerns about your family. So I think we can look into that more if you have a concern, before you do. I have my CFO here who can speak to some of that. I think maybe there's some of the specific concerns you might have run into that you can see the spouses care. We can get them. You mentioned a comment about inscription house, so that was really interesting. You mentioned that at inscription house, they tell you going to the, I think all of us were kind of raising their eyebrow because our understanding that's not part of our current experience. We welcome anybody from the inscription house to come here. We just, that was the first time I heard that comment or understood that it was being service up with all of them. On that, because we always understood inscription house as part of it, the end of service unit. And so, moving through Customer service is one of the things that we're working on. We are actually tomorrow with our board, we're running through our first iteration of our strategic plan. One of the things in our vision statements and our mission statement, is we really want to work in customer service. So we're working on building a better roadmap for that. And so with our board of directors and our new strategic plan that we're going to be addressing some of those things on customer service. Probably a more organized effort, but I think that would include, Mr. General comments around LGBTQ, because we recognize and we're getting a lot of people that want to be identified correctly, respectfully, and so that would be something that, one, is a little bit of training for my staff. And then working with our clinical teams about how we can address that more appropriately for all our patient populations across our organization. So that will be more to come for us on making improvements there. Dental services at Page School, I think that's been requested several times. I'm going to ask Dolly to speak to that a bit more because that is a what we acknowledge. I think our grants has certain authorities about where we can operate is what we can do to get money. So I don't know if Dolly can explain that a bit more.
Good afternoon again. The funding source that funds the Canyonland Health Center in Page, and additionally, the funding source that funds our mobile health and community health center is funded through an agency, federal agency, Health Resources Services Administration. That's a federal agency that funds both of those entities. And so when you get go into an agreement or a grant situation through HRSA, they require you to draw that imaginary line. And so by us going into this Page School District, you would be encroaching on their service area, literally in their town Page. And so our catchment area goes as far as Chichi. So that's where, so in order for, because they're funded, their programs, like their HRSA funds are funded for it part of their grant application includes the schools in their catchment area, which is Page, then we would be encroaching upon them. So it would have to be, we would have to have, it's very difficult to do that. And so that's something that we would have to discuss with the administration at Canyonlands. And so that's something that we would have to go into negotiation with them about, because it very much approaches on them and their funding and their catchment area.
Yeah, also since we brought up Page, that about expanding opportunities for those students. We can work on advertising better for that. The high school exploration program that which our HR team put together through a grant again. We were able to, we didn't have a lot of turnaround time, so I'm not sure how much media we got out there, but this is certainly something we want to continue to grow and to really advertise, because we do believe, many of us, like I mentioned, we came up from those kinds of programs. And so I think all of us here would appreciate it and really would like to do the same thing and turn around that kind of same opportunity for young people. So we'll look at doing a better job in advertising to other schools outside of just the city. Let's see.
Yes, as far as, excuse me, Julius Young second, hello. As far as the highway you're talking about from Salvador first windmill, we did, as far as Tuba City Regional Healthcare, we did submit a resolution in support of that. We feel that would be, one is accessibility as far as our ambulance and able to provide service on that. And so one of the reasons that they're recommended that is because we're building a new waterway facility that's not too far from there. So basically, that would mean a lot better traffic for them to come from Cottington also to, first windmill to the site there, but also we see that with the, here in Tuba, going to the back end of waterways, and those are two of the resolutions that we did submit, and we've been in discussion with NDOT, and there was a meeting a couple of years ago, right before the pandemic, we met with them where they were gonna add that into their master plan. So they asked for resolutions, and so we did submit those to them in terms of that. So as far as regathering and getting that going, we haven't heard from them yet, but we did ask on where we're at with that. So I was informed that they're basically going back and reevaluating what the past administration had to the current administration, so we're reevaluating that portion, but we did indicate that, you know, the healthcare is coming within another 2 years. In terms of it, that we'd like to see the road move forward. But I did bring up that when they built that 80/20, it was so unique to see all the agencies get together, I mean, NDOT, the county, the BIA, and just build that road in a matter of time. So I'm thinking that with that collaboration, that is something they could do within these two road areas in terms of it. So hopefully it's doable. Hopefully we're able to move forward with that as far as navigation.
There was a question about, or you mentioned the comment around OEH. So I think we can advocate and bring that to their attention. OEH, Office of Environmental Health is not under to the city. They just have space here. Their leadership and their administration and their supervisors are all under IHS in St. Louis. Brian would also be the person to speak about some of those concerns. I can relay the concern to him and letting him know that this is still something that they need to help to move. I'm gonna ask Ollie to address the question around payment, and the question around do we pay for the services for the medicine and CR patients.
Whenever we have a situation where someone doesn't have the money to pay for their medicine men or services, even beyond the area, we and the police, we get together, we put our money together, and we help that person. With all the combination. Thank you. So.
I think, I want to ask about, I think one of the latest things that's coming up from Arizona Medicaid is a rule, a proposal possibly to pay for or reimburse for traditional healing services. So that conversation was starting to come up at the state. Dawn?
I'm part of the Access 1115 waiver process. Started in 2016, actually, I think, convened an advisory group. And we were talking about reimbursement for traditional medicine services. So it really started out with hospitals and clinics across the mountain, and along with other tribes, especially down south, Pascagoula. There's a 40 healthcare representatives, different tribes across the state. We got together with Access down in Phoenix to start talking about reimbursement for these services. And they felt like the best approach would be the hospitals and clinics that was already providing services to help get that funding going. So prior to the pandemic, everything came to a stop. CMS was holding on to that waiver. So it restarted about 2-3 months ago. So they started back up again. CMS reached out to us again, asked us where we were. So that group is reconvening, and we're hoping we're going to get a positive outcome.
Moving on. Dr. Nez had asked about the top 3 or 5 reasons for patients to make our facility seeking services. I'll have to get that list, but off the top of my head, a lot of them are related to diabetes and diabetes conditions, diabetic conditions. Sometimes that's heart disease. So those are probably the primary ones. Dr. Ria, could you, I don't know, maybe you know the top 5 off your head?
I
You have to do a number.
I don't, Rebecca Arciano is reading that.
Top 5 reasons people, Rebecca Springer, Chief Nursing Officer.
The top 5 reasons people come to their emergency room are abdominal pain, upper respiratory infection, urinary tract infection, and orthopedic injuries.
So hold on a moment. Since it was Dr. Andy Nez's question, I'm gonna have you repeat that. He went out, it's for a little break, but since he's back, I'd like for you to repeat that.
Rebecca Springer, Chief Nursing Officer. The reasons why people come to our emergency room, I guess the top 4 are abdominal pain, upper respiratory infection, urinary tract infection, and orthopedic complaints and injuries. Now, the top 5 reasons why people are transferred out of our emergency departments are chest pain, behavioral health, gastrointestinal issues, and traumas. And neurology.
Well, the next one of our question was about fentanyl and our community response. One of the things we did do with our pharmacy team was they did do some education out to the community, the chapters. We probably want to speak on that a little bit.
Yeah, so, we did apply for opioid grant. Natalia Hitachi, Chief Ancillary Officer. So we did apply for an opioid grant that, gave us access to naloxone. It also allowed us opportunity to provide training. So, one of our pharmacist team members have gone out to several chapters providing education on opioids, and providing that education. We've also worked with the local law enforcement, to provide them training on how to use, naloxone, and then also providing them the resources so that they can, if they come across someone who might possibly be overdosing, they have the training to use the naloxone.
I think Dr. Nez, we also asked about large scale kind of community response efforts. Our safety officer, who's under the direction of our Chief Support Services Mentee, they, with the drills and the various kind of code read kind of events, we try to work with the local law enforcement and the schools should we have a mass event. So she does partner with them, work with them. We were trying to get an agreement completed with the schools. So in the case that we ever needed to collaborate, we have at least something in writing to keep that relationship open. So as in terms of mass penalty, that's kind of something that our safety officer oversees and works to explain. I don't believe we have an agreement in place. It's still an ongoing conversation with the schools. Childcare services. Glad you brought that one up because it does hinder. Some of our young mothers, young families. We don't have childcare services into the city, so that is some people ask to work part-time. You know, we try to be as flexible as we can. We looked into offering at one time before COVID. We looked into it. It's probably something worth looking into again because COVID didn't really follow through. But there was questions and concerns around risk and liability, especially with kids. But the bigger one is space. We're really maxed out on space in this facility, and I mean, we can only bring in so many modular trailers on our campus. And so that would be another issue where if we were to do this, that would be something else. We just have to kind of problem solve. So it's something worth looking into again. And it's something that does affect our ability to retain and keep employees. Top data, I addressed that earlier, and something that we need to look into more. And then the school, I think you asked me about the mobile schools. How frequently do we visit the schools? Val, do you want to talk a little bit about our relationship with the schools and the mobile visits?
Our mobile dental units, when we were applying for the grant, the focus for our mobile dental units are the schools in our service area. Right now, we have one mobile dental unit and we have 2 medical units. And we have a new dental unit coming at the end of this month or early September. And the reason we chose
versus going through the whole community, we chose the schools was because we were informed by our dentists at the time that Navajo children have the highest dental caries or dental cavities, different words, in the not in the state of Arizona or in the country, but in the entire world. And so that is why we felt like it was so critical to prioritize prevention for the kids in the school. That's why now we'll have two delegates to deploy to the schools in our state.
Then, we're kind of winding down towards the end of the questions here. The town hall, we don't, host town halls per se. We do have quarterly chapter updates. So they've been, before COVID, they were in person like this. And then since COVID, they've been virtual. So every quarter we have we invite all our chapters to participate in these quarterly chapter meetings. We give them updates similar to this. We usually have a couple of highlights. And then in the end, opportunities from our administration to kind of give an overview on some of our topics. And then Dr. Ned, your other question was about process. He wanted to know what that process is from the patients from triage. They come to our ER when they're discharged. I'm going to ask our CNO if she would talk to that a little bit.
So when a event sprayer, chief nursing officer, so when a patient comes to our ER, they go through a triage process, and that depends on the acuity and severity of their nature of why they're here, what they're presenting with. So all the nurses in the emergency department have what they call ESI training, which is an emergency severity index training. So if the person comes in, they're triaged, depending on what the nature of it is, if it's severe, if it's chest pain, they're bleeding pretty badly, they will go on back to the emergency department. If not, they'll go through a triage process up front when they first come in, and they're triaged based on their symptoms, and they get their blood pressure, and they take them to the back. They're seen by the physician, and that is when he determines or she determines whether or not the person needs to be discharged, transferred, or admitted. If they're admitted, they notify the hospitalists, and the hospitals and the ER physician, they report back and forth to each other and decide whether or not the patient's admitted. If it is, then they go through a process of getting the patient admitted, and they're moved to the floor. If they're transferred out, the ER physician works with, depending on what the problem of the patient is, to where they need to go. And they will call that facility to see if they can accept that facility. And they usually do an emergency department to emergency department transfer. It's easier than doing it to an inpatient. So the physicians talk, they decide, yes, this person needs to be transferred, and then the transfer arrangements are made. If the person needs to be discharged, they're given, prescriptions, follow-up appointments, and then they're discharged to where they need to go.
Can you elaborate a bit more on once they're discharged, what our discharge process is, and then maybe they're familiar with the case management of the patient once they're moved.
Once the patient is discharged, depending on where or not and what they need, sometimes they have to go follow up with case management to get durable medical equipment like a walker, or crutches, wheelchair. So case management works with that patient through the ED to get that what the patient needs. If the patient's admitted to the hospital once they're discharged, case management follows that patient, is assigned and follows that patient all the way through their care. So the next time they come in, they speak with that person, that case manager, because then that case manager is very familiar with them and they know their history. And instead of having to, it's really hard sometimes when you're trying to talk to somebody and you've already talked with 3 or 4 people about what the problem is, and you're having to tell your story over and over again. This way, each case manager has a set number of patients that they know, they're familiar with, and they take their notes on them. So it's just a much easier process.
I think you were also asking that same process in reference to the operation Rainbow Bridge. That was really unfortunate, that really sad that happened to our people. So vulnerable and really needing the services. So I think one of the things here, most of these, I don't know a lot about how many of these patients were moved down to these homes.
My understanding is it's not something we would have done from our ER, it's more of an outpatient basis, and it required coordination and communication. And approvals through Navajo, behavioral health programs. I'm looking at Dolly and I'm gonna ask Dolly to help me here. But once the patients are down there, you know, our case managers weren't really in the loop, to be quite honest. Since that has happened, though, Access has given us names, works with Julia Billy, who's not here today. Her case managers get the names of patients that have been impacted. And they've been reaching out weekly, and maybe with more frequency on trying to get them, if they're interested in coming back home, or at least getting them connected with other services down in the valley. I'm gonna ask all of you to step in because I think there's a lot more coming to this.
Good afternoon again. So when we were first informed about the sober living crisis in Phoenix, I attended a meeting with Access that was held in Phoenix at the time. And that was right about the time that the facility referred to as Solari, that was designated as the primary facility that either families from up here, healthcare organizations from up here, or patients that were in those living facilities in Phoenix. That was the primary facility that people were, the calling center, I guess, the call center. And they had a decision tree set up for the people that were leaving the sober living facilities, as well as families, both in Phoenix and here on the nation. And then also for healthcare organizations like the city that we could reach out to see if some of our patients were being affected. And we made sure that they had all of the information for to the city. So in case those patients were reaching out to them, they would in turn refer them back to us. So that there was a way for them to get home. However, for the patients that are choosing to stay in Phoenix, those individuals that were affected and were choosing to stay in Phoenix, that Native Health down in Phoenix set up that the referral source was Native Health for those families that were choosing to stay in the Phoenix area. As far as we know, we haven't heard any updates on that process since then.
So Dr. Ness, I believe that's all the questions, and I just want to thank Mr. Joe, also Delegate Harville, also Delegate So for his support, also in recognizing, you know, a lot of the things that we've done, but I really want to return the appreciation back to the committee and Mr. So, Delegate So for the advocacy on our behalf and for our community, because there's a lot of things that we can do, but our reach is only so far. And so, yeah, so for helping us and speaking up too, and learning with us and listeners.
Sure. Thank you, Tim. Thank you to the staff. Staff was hardworking individuals here that we really pride ourselves on. Their work, not their data contribution and providing the care. We as board of directors, we really have a lot to talk about to our communities. And really, I think our partnerships and working with other agencies outside of Tuba City as a Title V 628 organization, we really look to providing the best care, and I do appreciate you all as committee coming out. Yeah, it's I see we're going to be Muzare, candidates for the region. I think that's one of the critical things is we've always wanted to help our elderly. We want to provide that care for them. And how do we do that? You know, that with Kaibito Independent Living Center, we approached NHA to do like an offset for those who are living there. Those changes of people on the way, but no. Pesos scheme. A lot of that is being placed back on our elderly residents. We got to put those price and you know in the market value, and that's being pushed off to the elderly. For other, funds, in case the board members, but it up. God, we have grants departments trying to see. Let's go sit back down at HA. See if they can get some type of funding for them to help offset the costs. I don't, I think though, based on, I'm not going to be. Community to not check on. The cover and that same shit though. Because we don't suddenly achieve God of check out. At least some type of funding, I think that can be done. We'll do our part, and then we do have Mr. McWade with his foundation. In Navajo Hopi Health. See that the details of I thought that. And say go. She would go back in and said we have our CEO here, or COO, or senior leadership in the hospital. We're very closely with people's champion in the situation that one of the council delegates so gone to bat so many times, including to what this hospital means to him and his community. I don't know for the chapters what that everything that we network since upon this stuff in Colorado to the city there. I don't chapters don't think that we don't have tell us something how you hope you try though. Didn't be called. I don't I would cut nature. I think it's something a lot of it's just a matter of prioritizing what gets done. So it queens and shit sends and they report the shit sends and the even about needs, about the needs. We don't piece of a shiba is. I could and this I think she not know the man of Zado. It is not all the ones that she could over a husband. John Taylor that he was shouting at this and there's always opportunity to all together meet with us in the future. Even out of source, I think it's fun that we can end it. On spot. I think the board is very open to having these type of discussions and see how we can grow even further with all the projects that you've heard. I want to commend and people those our COO, Mr. Young, I don't know, Mr. Black, they've been maintaining there with their staff. A 75-year-old building, a 50-year-old building, and maintaining that compliance and standards. They will use it as on the joint commission that you have get this done. Hold on now, that means you have all these nice facilities, youth on level, work compliance. They have new buildings going up now, kind of. Not thinking, we won't need a new building, but they do what they can with their staff to really keep it in compliance and really maintaining that. And you can let them it's HTG, all these different tribes, they're always asking about what the city doing. So what are you doing over there? It's a what you're doing over there. Honorable soul, even that to the city that they went to Ross they never had this. She said, we give them that constant communication. So it's after we're always open to our new delegates representing our area to contact us. Let us know what information you would like. So that's where we're at. So I'd say thank you. Mr. Nash, yeah.
Okay, but Rashid, again, we still have some follow-ups as well, some questions, but I do want to caution that to my colleagues here, we do have a scheduled tour of the facility. So if some of your questions would also be at that time, that's fine. They're very critical, and my suggestion is to of course asking now. But we do have that scheduled following the agenda of today's meeting. But thank you to your team for addressing those. First, I'll call upon Honorable Vice President.
Thank you. Chair for town. Dr. Andy Nez, and then Dr. Hatton, other you can pass now from just one thing, a few things, but I think that's critical that we haven't really, I think we've not really ever talked about is just along with the sober living facilities and those businesses is the non-emergency medical transports. So some of the issues that come, in the past, I don't think the Navajo Nation Council or Navajo Nation leadership has really ever advocated on behalf of our Navajo people, as a government to government relation with the state of Arizona. And so I know what is needed there is also advocacy from the healthcare facilities in terms of the issues that you come upon when you're, when these, companies are trying to get our people to some critical services. They travel all over the place because, down in Phoenix and Albuquerque and wherever these, specialty clinics are. What you've alluded to that you're, looking at those cases rising, folks needing those specialty services. So one of the specific issues is I know, companies have complained, people have complained about Access now requiring a referral from here to Sacred Peaks in Flagstaff. And the facility here has responded to the non-emergency medical people that we don't refer to our own facility. It's one of our, it's our own. Why would, the referral is really from one facility to another that are not related. But in this case, you're related. That's your you're a branch out there. And so clients have not been able to successfully get that transport service because they're not able to get that referral from here to Flagstaff. So that was one little specific. And I think in some ways we have to keep that line of communication open because we are going to prepare to start having some of these conversations with Access in terms of what kind of issues that we're coming upon. And with Access, there's so much education that we have to provide to them because they are so unfamiliar with our homelands out here. And I think that's something you talked about. What I did, again, the Access consultation and paired up. Access did mention that they're going to really, as if they're bringing funding back to the I'm just going to call Office of Native Medicine, so traditional practitioners. And so I was just, letting my colleagues here know that we really need and I was the only one that went to pair it up, but we need to bring Access to our CAS meeting because it sounds to me like there's so many resources that they have, some specific to Native communities that we really need to take advantage of. And last but not least, I think when you become 638, anybody who becomes 638, you're really, communicating that you are, you have all the skills and capabilities to run a business, because that's basically what you're doing. You're running a business. And you're saying that I have all the expertise, I have all the knowledge to do this on my own, without the help of the, we can do it on our own as a community. And so I speak in this in terms of not only with hospitals, but also with schools, because as you know, HES is oversight to the schools. And we're just seeing so much, things that are not being done right, in which our students in the school situation are suffering. And then also with hospitals, with our clients and whoever are people. So that anybody who wants to run 638, and this is not specific to you here to the city per se, but just anybody who wants to run 638 or wants to run a grant school, make sure you have all those, people with the skills, the business skills, the human resource skills, management skills, and mostly communication, collaboration, partnerships. Those are real critical to run those ships. Because if you don't, you're doing a disservice to our people. And so with all the schools and all these places that are going awry, you take on that heavy responsibility and you're saying that I can do this work. So take care of it because it takes care of our people, and that's who we're doing this for. At the end of the day, it's about the people. So
Yeah, Vice Chair. I'm holding it again.
Oh, okay, that's a follow-up question is that, I'm still gonna say this again for my communities of Pukuchi and Copper Mine, Waterway Gap. And kindly told that, you know, that our children, most of them are bused into Prince Unified School District. And we have transportation from the school, from the Cheney facility to where they can get dental care. And, I still want to say that, and I'm still going to advocate for that. Candy Land will not do nothing for our medical kids. They won't provide those services for them. Of course, some of them, Candy Land wants to be paid up front and all that. The Pay School Unified School District, they have transportation, they have loans, they have long buses, where they can bus the kids out to the cheating. And get their dental with them. Yeah, I mean, not stop, not stop. Auto for the water line extension to Copper Mine and part of Kaiwi over the cheating, you know. Yes, it's under, now that I know that it's under IHS, but you guys, you know, we still need your support. We're still in the region, and this is a health issue, and it was part of COVID too. So again, now we are sure they advocate for us. So that's why I just want to follow up on. Right, thank you.
Okay, guys, any other questions, follow, comment? Honorable Paul?
Okay, we should got me people. Yeah. Yeah, just so yeah. Colores is all, just some way I mean. Your organization is capable of doing yourself. The best way to do it is trust each other. About the so customer service is very important. You know that. Our staff. Staff that you have, I've been, like I said, I was with law enforcement, and then became a politician, and worked for IHS. We possible. What I see there is customer. A lot of our staff and not often that they're elderly, especially, and now who gets. But the many people in each of the carnival area, young people. That's what's happening. I've seen that. You know, two eyes, two also at this hospital mention. That's what I can see. Like yesterday, I was in Gallup in the medical center with my daughter and the kids. And this individual came in because he had a stomach. We went to this one window. He was telling this young, this patient was telling this lady, hey, I have a stomach. The stomach's hurting, can't breathe. Here, fill out the paper. Guy just dribbled on and gave it back. Now go over there. You know, well, I hope you don't have that kind of system. Yeah, when you want to see a doctor, if you're in pain, you should get a system like that instead of paper. You know? So I hope you don't have that. This individual went to this group. Later on, he was told, go over here and sit down here. There's no professional. But probably I'm take. I hope you sponsor those type of training for your staff to AI. So because even now, that's what I think. If you want your customer to be come back to you know, to the hospital, you have to treat them nicely. How do you want to be treated too? You're in pain, you know? So those are big issues. I know you guys tell your staff, you know, equalize for the students, especially elderly. And a lot of these the first line people that you're talking about, the most stigmatic. how you communicate with the elderly that comes in. So that's very important, you know. But, no. Even, you go to a doctor, I have for interpretation. You can, but we looked at that also. It was with. It was that, not this chair, I don't know, yeah.
Okay, yeah, with that, I'll turn the floor back over here to the secretaries to the committee for help. To address the comment.
Thank you again for the comments. The non-emergency medical transport, I think, we can work on advocating again. It's kind of something I'm not all that familiar with, but I'm not involved in too much. I am concerned about the referral from Care 5 that's obviously incorrect. We would have to do that education for Medicaid. I think too, it will cross the line for us to refer to our own hospital. That's a start issue. So I think it's an education for access to understand that they are part of the city. I'm not sure why we would refer to Sacred Speaks and kind of confused about that. So we'll have to look into that a little bit more. And if there's opportunities for us to educate access, what we're doing, we can do that. Let's see. Yes, I think the access issue, I appreciate the comments around the communications 638, and I think that's one of the things that our prior CEO with that one, and the board as well, in succession planning, we recognize, we understand that this is a business, and it's a lot. Trusting the healthcare into our hands, it's important, but we want to make sure that it runs well. And I know our board is very they advocate strongly for their communities. And our CEO, prior CEO, set up an mentoring program so that they address those issues around leadership, communication, building trust, building teams. So, it's applying all those things we've learned even in our degree programs in leadership, and using that to keep the organization running, making sure that it runs efficiently, and collaborating with the board, collaborating also with stakeholders. So I think that's, I appreciate the comment, and certainly that's something that we are very, I think, will acknowledge that we do want to make sure that we have the right skills coming in, because it takes a lot to train, and when you lose employees, that takes a lot too, and having to retrain them. So that's important for us. Then we can continue to see how we can help the Page School and work with Ryan and others about how, if they can bus them to achieve, the service already exists and we already know how to do that here, so I'm just doing it another site, but maybe working with the Page School systems to see how they can bring students to us. I think too, I am part of the Arizona Alliance of Community Health Services. So the community lands comment you made about how they're not going to. That's a comment I will certainly take back to the CEO of the organizations there, because we sit at this kind of table with all the CEOs of the community health center, and I can let them know about this particular concern, how that needs to be. And then, not on the customer service, that's an area that is a concern for us across the organization. One of the things that the city has done was really expanded services, access to care. We've seen our presentation, you heard where our footprint is. Now we're bringing the quality up with it, and that's been our focus: quality of customer service, improving our data so that people will get good sound data so we can make better decisions. That's kind of really where we're at today, bringing that lift up. But I think the board and our senior leaders here, obviously, we heard from all of them. They're experts in their areas. They do a tremendous job in making this organization run. I really appreciate all of them and their time and attention here in addressing the questions we all have. And thank you again to the board for their advice.
Mr. Chair, rather than to recognize Ron Hamiento, the representative of the Mokofi Village Upper Loading from Mokofi. Just to restate to the committee on how your community
Good afternoon, Rob, I'm here to again on the board of directors for the city region. And I represent the lower and the multi village. This position wasn't filled for quite some time, I believe 3 years at the most, maybe 2 years. So it's really good to be on board and listening to my community. I've heard nothing but good things as far as the healthcare that we receive, especially during COVID times and during now. Being at this table and talking about the unit for my community, not only just for the local people, but for PIU and that ultimately as well. So it's really shown me a lot about the healthcare. I was in law enforcement for 27 years retired. This is definitely something new to me and something that I want to continue to learn about the healthcare part of that. And I also am a director for my own chapter department of public safety as well. And I also oversee police department, fire, EMS, and that plays a huge role as far as for my community. So it's really an honor to be on the board, to be here to listen and you all here, and thank you for coming. So for my people, it's been excellent. Even myself coming here in the hospital a few times, excellent service. And I hope to continue in that direction of providing quality service to the community. Thank you.
I'm going to thank that for sharing all the information for your facility. South Home Medical Center, which is right in my backyard. So it's really nice to be educated on your facility here and the service you provide to our Western relatives. I don't want to thank Roshanella for joining us today. I know he brings a wealth of knowledge and advocacy, even on the floor. He's one of my mentors. I consider one of my mentors. A lot of accountable exchanges. And Mr. Phil, I'm sure through your comments has been very supportive of the since their turn. So that does speak a lot about what he does for our communities out here in Western New York. So thank you. Before I go further into closing remarks, I do want to give an opportunity again to Roshanella.
Here at Tube City Healthcare Corporation in Tube City, and our neighbors, near each other. We try in Hopi Village, the upper and lower village. I don't know, we have San Juan, IU representative. We all share the common interest in healthcare. And this healthcare corporation right now, it's pretty much providing that balance because their numbers, we try on how you try is included in some cities, yearly. It's in the request. But there's other things that give this area to public safety. We're still trying to find that divide there or that gap to close. A couple of days ago, there was a incident against country fascists, and it becomes a jurisdiction issue. And that's what the healthcare runs into. The other reimbursement for individuals who are incarcerated. When I believe Senator McCary is still around, he was moving a bill so that individuals incarcerated who need medical attention are brought here. Their care that's provided for them is not reimbursable, even though they're Navajo or May okay or Paiute. It's due to the politics of how the wording are in with the healthcare. So to the city police department, someone incarcerated needs medical attention. You bring them, they don't get reimbursed. That's another issue. And somewhere we have to work forth on that to continue that advocacy to try to get reimbursement here. Or a person coming from Gallup, by the Gallup region, like I'm a Chave area, he or she needs medical attention. And they fall under that circumstance. Like a bed or somewhere we have to find that, that balance there. The reimbursements have to be because, at one point, I did hear, if someone, I forget, but they were told, they'll give like, in the FDA saying that, you gotta get service over there, go over there, things like that. It was somewhere, I forget. No, it wasn't Sanders. Some of our relocatees that relocated from this region and they were directly impacted. Family member was told that they went to 30th out of Gallup. So as they had to get information straightened out, that's when they were told, okay, you're gonna be counted over here because when you go into that region too, and this is tied to Navajo Land Commission, that community utilizes that also. And that community utilizes Gallup Service Union. And that community utilizes Zoom Health. And the issue will be the reimbursements. And I mean, that are just based off our analysis, human energy. Well, this area is probably looking at the same scenario there with your neighboring tribes, the huge tribe in their facility. So, chief of the jurisdiction boundary, and in this case, we have a safety issue too. And when our officers come across, they go over to help them out. And we come in the nation comes issues such as liability issues because they're not covered. It's considered off the reservation. This meeting at Multiple Legacy Inn requires an off reservation travel for any travel employee because of the jurisdiction. So just to you the land status and that we're trying to get sorted through this beginning. The land status that we're on is Secretary of Order. And it's a form of the eminent domain that has been imposed by the federal government on the Navajo Nation at one point. That could be able. At times we have to go back here to the federal, to the Bureau of Indian Affairs. So it
colleagues, has committee members, any final questions? Thanks, was. Carries, hearing none. Thank you again. CEO, to your staff, all of you for being here with us. I noticed that you just saw the back of my head. But thank you. I would say I can be a healthcare professional. I think we bring something different and unique to the table. My background is in education. I love working with children, with students. I have been teaching for 4 and 5 year olds, but I know sometimes healthcare professionals, that's not the case. So just vice versa. Thank you for all the work that you do. And actually, so when you know this quiet at the hospital, and then I really see yourself in that. Thank you for bringing us to the agency, meeting with our relatives. I always enjoy the drive here. With the be able to for our people, for yourself, take care of yourself as well. Especially that be able to take care of others, you take care of my colleagues joining us this afternoon. Morning. Yeah, colleagues, I'm going to a roll call vote to accept the report here provided by the City Regional Healthcare Corporation. With that. I vote Lynch James with a few. Honorable Jermaine Simonson, Vice Chair.
I vote green.
Honorable George Toll. I vote green. Honorable Curtis Nito. Green. And with that, colleagues, we have 4 in favor, 1 excused, Chair Pro Tem voting. With that, thank you again. Moving on to our agenda, item 6, old business. There are none. Item number 7, new business, there are also none. Item number 8, close of meeting, any announcements? Colleagues? Sure. Honorable.
Can we place at this for a special meeting? Anybody? So, to let you know. For 25 Friday, right?
That is a special nomination council meeting. Those council meetings by request only get initiated with 13 vote, 13 signatures from 13. So, it may or may not occur on Friday. Any other announcements? Our next regular scheduled head meeting is on Monday, August 28th. For our listeners and for our members here, the recent 25th nomination summary session, we did pass legislation by the HES committee and with the nomination council to have our HES meetings on every Monday except the first Monday of every month. So if you have an opportunity to listen to other reports, feel free to tune in as well. With that, I don't have any other announcements or anything. You all can say thank you again. Enjoy the rest of your work week. So with that, I'll call for a motion to adjourn. Motion by Louisville Vice Chair, seconded by Honorable Curtis Muto. Colleagues, any questions or comments on the adjournment? Hearing none, I'll do a roll call vote. To adjourn to Honorable Honorable Vice Chair, Chair, and Shane. Honorable Honorable George Cole. Honorable George Cole. Honorable Curtis. Okay, with that, colleagues, staff, you have 3 in favor, 1 not voting, 1 excused, Chair Pro Tem not voting. You call this meeting adjourning at 3:17 p.m. local time. For the phone or the yeah. Yeah.